Good afternoon, ladies and gentlemen. At the outset, I'd like to thank the organizers for giving me this opportunity to speak on this topic. Orthobiologics is a rapidly evolving concept. It basically deals with these naturally occurring substances which are present in the body, which help in healing musculoskeletal tissues, bone, cartilage, muscles, tendons, ligaments. When used in higher concentration, they hasten the healing process. So this tremendous scope is there for the orthobiologics, otherwise called regenerative medicine. It involves in regeneration of damaged tissues and organs by stimulating the repair mechanisms to heal and also to grow tissues and organs in the laboratory and safely implant them. Approximately 1 in 3 Americans could potentially benefit from the regenerative medicine. From replacement to regeneration, from removal to repair, we are moving into anabolic era of orthopedics. The inspiration comes from this little animal called salamander. When you cut its limb, it grows bones, muscles, tendons, everything. A complete limb is grown. The first generation of orthobiologics or viscosupplementation, basically hyaluronic acid, which is naturally extracted from biological sources, being used as intra-articular injections for arthritis, produces anti-inflammatory, antioxidant, anabolic, and reduced cytokinin effect. It also reduces the pain by masking nociceptors. There are no systemic effects with this, unlike NSAIDs in elderly. So therefore, it's particularly useful in elderly. Plus, be aware that it's not recommended by neither AOS nor NICE guidelines in the UK. Platelet-rich plasma is the second generation orthobiologics. It is emerging as the orthobiologic of autologous form, contains bioactive proteins and growth factors, which have regenerative and healing properties. It stimulates a supraphysiological response and jumpstarts the body's natural healing response. Because patient's blood is used, which is not considered to be drugs, the treatments are not subject to FDA approvals. So PRP is shown to be superior to the first generation in OANEs, but it is more evident in tendinopathies and becomes mainstay of treatment in professional athletes. Celebrity athletes like Heinz Ward, Tiger Woods, and many international players have been using this and found very useful, and it became very popular with the usage on these people. Cell therapy is a third generation orthobiologics. It causes anti-inflammatory, immunomodulatory, and chondrogenic properties, the core foundation for regenerative potential. It also induces differentiation and proliferation of resistant stem cells. At the moment, the authorities only allow minimally manipulated cells, otherwise called point of care. The core concept for orthobiologics is understanding the healing trinity, where three factors are involved: growth factors, stem cells, and the matrix, otherwise called stimulants, cells, and scaffolds. Growth factors act on stem cells to do the repair of the injured tissues, whereas stem cells are summoned during the healing process to the area repair. But matrix provides framework for stem cells while they grow into mature cells. Growth factors cause stem cells to the injury by a process called chemoattraction. They can be produced by genetic engineering. The best example is bone morphogenic protein. BMP2 and BMP7 have a great role in bone formation in various clinical situations. Platelet-rich plasma contains a plethora of growth factors and mediators in their alpha granules. And there's a whole list of growth factors which are available in them, which are very essential and play key role in tissue healing. It was first used in 1988 by facial surgeons, and they found that the group who had PRP, the consolidation of graft was far better compared to the control group. Since then, it's been extensively used and published in osteoarthritis, apart from tendinopathies and enthesiopathies, either alone or in combination with hyaluronic acid, and found very useful. We had our share of publication, and in our experience, we found that it's very effective, especially in early osteoarthritis. So, ladies and gentlemen, it was hype, but now there is evidence and scientifically proven. Therefore, the list of usage of PRP is growing. Cell-based therapies are again becoming very popular and more accepted. Basically, they are connective tissue progenitor cells capable of differentiating into various connective tissue phenotypes. Three types: mesenchymal stem cells, human embryonic stem cells, induced pluripotent stem cells. Out of that, adult mesenchymal stem cells are readily available. They are autologous sourced from bone marrow and fat. There are no major ethical issues involved and can be expanded in vitro, and they do not express antigenicity. And therefore, their usage has been increasing. Out of the three critical areas, bone defects, non-unions, vascular necrosis, and cartilage repair, where from replacement to regeneration, from removal to repair, a concept is growing. The mesenchymal stem cell usage in avian, with this paper, very respected paper by Heringo, made it more popular, and they found that the number of patients requiring total hip replacement where stem cells are used far less than the control group. And this is some of our example. Another critical area is the cartilage repair, where the cartilage grown from the stem cell usage was good hyaline natural cartilage. The repair is natural. Bone healing is another area where for years we've been looking for mechanical solutions for this biological problem and often ended up in situations like this. Whereas now we're increasingly looking for biological solutions to biological problems. So stem cell usage is becoming more popular. Extracellular matrix has been recognized as an important key factor. It provides structure for cell growth, contains collagen and polysaccharides and glycoproteins. It provides carrier for stem cells and growth factors for precise placement. Bone grafts are excellent scaffolds, both autografts and allografts. However, demineralized bone matrix now available with the softening bone, and it still contains collagen and growth factors, and it is osteoconductive and osteoinductive. Ceramics, synthetic biodegradable scaffolds, composite scaffolds are all available in various powder form, paste form, and liquid form. Of late, amniotic tissue has been recognized as a graft. It comprised of an extracellular matrix, and it has natural collagen scaffold, and also contains hyaluronic acid and host of growth factors, and it is commercially available now. Some companies even claim that there are living cells in it. If that is the case, it provides complete healing trinity. So the scope is growing. Last year, over 5 billions was the market of orthobiologics. Well, is there evidence? Yes, there is enough evidence. Plenty of publication has been there. Out of that, this credible paper by American Journal of Sports Medicine 2019 clearly shows that PRP usage in osteoarthritis and its effectiveness. However, there are limitations. There is lack of standardization regarding optimal composition, technique, dosage, volume, concentration, cell count, etc. And also there is lack of high quality reproducible research in this field. What about ethics? When the patient runs out of all the options, we try to give this magic medicine, magic treatment, and some people try to take advantage of this rather desperate patients, and boutique clinics and all healing treatments with celebrity endorsements are coming up. But please see this FDA statement. Companies and physicians exploiting desperate patients and profiting from the sale of treatments that are not fully proven are still categorized as experimental. Here is a man, Yamanaka, who has discovered that an adult cell, any adult cell, can be induced to pluripotent cell. A tremendous leap in this field, and he got Nobel Prize for that. And he is an orthopedic surgeon. So with this, tissue engineering is growing leaps and bounds. At the moment, a human ear lobule has successfully been created, and a beating mice heart, and even myocardium has been, human myocardium has been created. So ladies and gentlemen, we are scratching on the surface of this immensely potential area. So therefore, orthobiologics, it was hype, now it is science and hope. In terms, especially in sports medicine and musculoskeletal injuries, where we are moving from interventional orthopedics to interventional orthobiologics, from more invasive orthopedic surgeries, moving to less invasive non-surgical injections. And it is evolving as a middle ground between conservative treatment and invasive surgical option. Thank you very much.
Good evening to respected seniors and colleagues. Today's my topic is extraction and processing of platelet-rich plasma. Few basics about platelets. They are discoid in shape, 2 microns diameter, lifespan of 7 to 10 days, granulated with dense alpha granules and lysosomes, which are sources for growth factors. As they are very delicate, we should handle gently. Main aim of prevention of degranulation during processing and extraction. Assure sterility with point of care. For tissue repair, we require minimum 1 million of platelets per microliter in a PRP. Growth factors which are present in PRP initially stabilize the damaged tissue and helps in migration of mesenchymal and epithelial cells and helps in collagen and matrix synthesis. Vasoendothelial growth factor and fibroblast growth factor 2 helps in neovascularization. Growth factors which are present in PRP mainly helps in tissue repair, regeneration as an analgesic and anti-inflammatory. The extraction of platelet is done by 2 stages. The main goal is to maintain the properties of the platelets. Stage 1 is phlebotomy. Stage 2 is processing venous plate. Phlebotomy is done by 21 gauge scalp vein set pre-filled with ACDA solution. Avoid hypodermic needle as it causes endothelial injury leading to platelet activation. Initially, 3 ml of ACDA solution is taken in 20 ml of syringe, 17 ml of blood drawn. In ONE, total we collect 40 ml of blood. 0.3 ml of blood is sent for initial platelet count. All measures are taken to prevent activation of platelets. ACDA is the only anticoagulant solution used in PRP because it stabilizes the platelets, it keeps the viability for 6 hours, prevents spontaneous activation. Clinically accepted solution and US FDA approved solution as it is sterile and non-pyrogenic solution. So much confusion in the literature whether to use single spin or double spin technique. Because of higher platelet capture efficiency, we have chosen double spin method. Leukocyte rich versus leukocyte depleted. In most of the orthopedic conditions, leukocyte depleted PRP is used. Plasma based or Buffy coat based method, we used plasma based method to achieve leukocyte depleted PRP. And the technique used for platelet are gravitational platelet sequestration technique. Our main double spin technique consists of initial first soft spin of 1500 RPM for 15 minutes, second hard spin 3500 RPM for 7 minutes. Stage 2 consists of 3 steps. Step 1 of soft spin. Once after phlebotomy, syringe nozzle is capped, piston is unscrewed from the syringe. You can see a special syringe in the diagram. Once after unscrewed, it is placed in the centrifuge as shown in the diagram, and RPM is set as 1500 for a duration of 15 minutes without break. After the end of soft spin, blood is separated into 3 layers. At top, serum and platelets. In the middle, Buffy coat. At bottom, RBCs. The serum and platelets are drawn into new syringe through Luer connector, avoiding aspiration of Buffy coat and RBCs. Combined volume of 16 ml will result if you collect 40 ml of blood. Counterweight of syringe is placed in the centrifuge and second spin is set of 3500 RPM for 7 minutes. At the end of the hard spin, plasma is separated into 2 layers, platelet poor plasma on the top and platelet pellet at the bottom. The supernated plasma is discarded, leaving 2 to 3 ml. 2 to 3 ml. The plasma is reconstituted with platelet to form PRP and sent for the counts. You can see in the picture, the platelet count has risen 7-fold and leukocytes count has depleted 8 to 9 times. Is there any role of activation of PRP? There are 2 kinds of activators. exogenous and endogenous. Exogenous activator is by thrombin, calcium chloride, and mechanical trauma. Endogenous by collagen, which is available in local tissue. In most of the orthopedic conditions, we don't require any special activators. Only in LONE, activators are required. The common dosages which we are following is knee joint 3 ml, tendinopathy 1 ml, diabetic wound 2 ml. And dosage intervals are 3 weeks interval for osteoarthritis, weekly for diabetic wound. Post instructions are NICDs should avoid as COX-2 inhibitors, which depleting the growth factors properties. Cold compression is done for decreasing the pain and swelling, and strenuous activity should be avoided for 48 to 72 hours. As conclusion, optimal platelet concentration of 1 million can easily achieved by this technique. As closed system, there will assured sterility. As a point of care procedure, it can be done everywhere. Compared to the commercially available kits, it's very economical. Thank you.
Thank you, Dr. Ram Reddy, for your presentation. Now, I request the viewers, if there are any questions, they're welcome. Dr. Ram Reddy, how come the commercially available kits are different from the one which you are now using? Can you elaborate in a brief way?
Yes, sir. Yes, sir. Good evening. The most
Good
of the commercial available kits are single spin based methods, and their cost ranges from 6 to 10,000. And most of the times, counts are not consistent. What we observe, this kit which we are using is giving consistently about more than 1 million, and even leukocyte depletion is more consistent. In commercially available leukocyte, we can't say depletion.
So you mean to say that the yield is very high. The yield is very high, and leukopenia is better. So therefore, the quality-wise, it's better.
Yes, sir.
That's what. Okay. Yeah. Okay. Any other questions from the audience? If there are no questions, we'll move to the third talk.
Thank you very much.
Thank you. Thank you very much.
Good evening, ladies and gentlemen. Let me thank first the organizers of ASISCON 2020 for giving this opportunity to be a part of this esteemed conference. I am going to speak on the understanding of the biology of PRP. As we all know that platelet-rich plasma is now being used as the regenerative tool in musculoskeletal conditions. But one should know how this PRP functions and what is injecting into the target area. For that, we need to understand the biology of PRP, which is nothing but what are the various components of PRP, what are the various types of PRP, how does PRP once injected, it acts in the target area, and if there is any activation method both in vitro, in vivo, we need to know that. Platelet-rich plasma is consistently defined only by the absolute quantity of platelets, which is usually 1 to 2 millions per microliter, and not by the other components. PRP is usually prepared once the peripheral blood is drawn. It is spinned a couple of times in the centrifuge at a particular speed for a particular duration of time, and the high yield of platelets have been obtained, and it is used as a PRP. PRP is not platelets alone. It also has WBCs, fibrinogen, fibrin, and various growth factors that are released from the platelets. And how the platelets function, they release various types of cytokines which are either giving an anabolic effect which is used for the regenerative tool or as an anti-inflammatory cytokines that thus helping in the pain reduction. The various anabolic cytokines that are released from the platelets from the PRP are very many. The most important of them being a transforming growth factor beta and platelet derived growth factor PDGF. Out of them, the transforming growth factor beta helps in collagen synthesis, and the platelet derived growth factor is a key growth factor. Normally, the amount of cytokines in the PRP are 3 to 5 times that of the normal plasma, which enhances the anabolic activity and ability to induce the chondrocytes and tenocyte differentiation, thus used as a regeneration of the damaged tissue. But the amount of growth factor concentration is influenced by the degree of contamination with WBC and the storage conditions like the temperature and the time from the initial preparation of the PRP. The presence of WBC, they being catabolically active, they have a negative association with the matrix gene expression and positive expression of the catabolic gene. Therefore, the presence of WBC improves the inflammation rather than the regeneration. And this kind of PRP, which is having leukocyte richness, it plays an important antimicrobial role and thus helps in the wound healing property of the PRP. And the ideal orthopedic PRP preparation should have high amount of platelets to that of the WBC, thereby promoting anabolism or the catabolism as a regenerative tool. The presence of the fibrinogen, depending upon the type of the fibrinogen, whether it is soluble, the PRP is liquid, or if it is having a fibrin matrices, it is a gel form of the PRP, which helps as a scaffold for the tissue regeneration of the target area. Based on the leukocyte amount, the PRP formulations can be leukocyte rich or leukocyte poor PRP. The presence of the richness in the growth factors, a platelet rich growth factors. And when the fibrin matters are very many, as we already discussed, PRP can be used as a gel form that can be used as a scaffold. And then subtypes of the PRP based on the leukocyte presence and the activation, whether it's non-activated or activated, and further subdivided depending upon the number of platelets, that is more than 5 times or less than 5 times. How does the PRP can be activated? In vitro, it can be activated by adding calcium chloride and thrombin or repeated freezing and thawing. Whereas in vivo, once it is injected, as it is exposed to the collagen that is damaged at the target area, it can be activated directly. How does the PRP acts when it is given into the target area? It delivers a concentrated dose of the growth factor which enhances the healing process and also reduces the pain by anti-inflammatory effect. When it is injected into the joint intraarticularly, the synovial fluid homeostasis is obtained or restored by direct stimulation of the synthesis of the hyaluronic acid, and also it suppresses the concentration of the various chemoattractant cytokines within the synovial fluid and thus dampens the inflammation. And this anti-inflammatory response of the PRP, as it breaks the catabolic loop, it directly dampens the inflammatory response in both synovial membrane and articular cartilage. The two mechanisms by which the PRP helps in pain relief and it is injected in the knee osteoarthritis. One, it decreases sensitization of the joint nociceptors by directly suppressing the NF-κ-beta on the intraarticular inflamed cells. And secondly, it targets the endogenous cannabinoid systems and thus it reduces the pain and inflammatory in the knee osteoarthritis. Presently, the PRP is being used in various musculoskeletal conditions like tendinopathies to the cartilage degeneration, which is very commonly used as osteoarthritis. In ligament pathology also, we are using it regularly. And finally, one need to understand the biology of the PRP. Before that, we need to understand the biology of the tissue repair mechanisms and how this PRP, various contents, how they are useful for this repair. And by understanding the biology, we can improvise the PRP formulations and thus apply in a better way. Therefore, the effectiveness of the treatment outcomes can be improved by applying PRP in the target tissue. But The most important thing is the optimization of PRP is still required in terms of its timing, the dosage, the volume of PRP, the frequency of injections, the composition of the PRP, and the post-injection rehabilitation. Therefore, by understanding the biology of PRP, we can improvise the treatment outcomes. Thank you very much for the patient hearing.
So, dear friends, this is biology of PRP. One should know what we are injecting. And I now invite any questions regarding the biology of the PRP before progressing into the next lecture. Any questions are welcome, or any comments. Please unmute before asking the question. Therefore, it is audible to all the people.
Good afternoon, sir. Good afternoon. A quick question for
Good
me.
afternoon.
Hello. Have you found any clinically significant difference while using leukocyte-rich or poor PRP?
Yeah, definitely.
Yeah, definitely.
If you use a
leukocyte-rich PRP, that causes compromisation of the final outcome as compared to the leukocyte-poor PRP when it is used as a regenerative tool. There are many papers, and that's our clinical experience also.
Okay, sir. Okay.
Thank you. If there are no questions, I move on to the third lecture. This is by Dr. Charan. He is an investigative pathology and also the director of comparative and experimental pathology from Kansas University, USA. And he is going to talk on the molecular mechanisms of the regenerative medicine and the basics of the orthobiologics. Now, I request Dr. Charan's talk to be delivered. Thank you.
Good evening, everyone. First, I would like to thank Dr. Krishna Subramaniam for extending this invitation today for me to present at this conference. I also like to thank the conference organizing committee for making this event possible. Quick disclosures, I'm a scientific consultant for Stennavel Biologics, Kansas Regenerative Medicine Center, and Enzo Discoveries. So the term orthobiologics that has been widely used, which means healing by use of biological substances that are naturally found in body. This orthobiologic can be an autologous or an allogenic product. So here are a few of those that I put here together, include tissue grafts, extracellular matrix, blood-derived products like platelet-rich plasma, cellular therapy using mesenchymal stromal cells, and also other acellular products like extracellular vesicles, etc. For today's discussion, I'm going to focus on platelet-rich plasma and the mesenchymal stromal cell mechanisms. Before we go into understanding the molecular mechanisms of regenerative medicine, it is basic to understand the pathogenesis of osteoarthritis. So for the context, I'm going to go on a quick refresher on the pathogenesis of osteoarthritis. So with chronic mechanical stress or trauma to the cartilage, there is this initial events that causes or initial factors that cause cartilage to release these matrix metalloproteases, which sets up a chain reaction into further cartilage degradation by activating the synovial membrane that releases more cytokines and triggers more pro-inflammatory cytokine response, eventually leading to accumulation of synovial fluid within the joint, loss of cartilage, thickening of this synovial membrane, and subchondral bone remodeling. So these molecular changes sets or paves paths for the phenotypic changes where you will see loss of cartilage and subchondral bone exposure and leading to osteophyte formation due to increased bone resorption activities or bone remodeling activities. And also the synovial membrane undergo thickening due to increased fibroblast proliferation. So what is platelet-rich plasma? So coming into the understanding of this, this is basically a refined product of autologous blood with a platelet concentration that is slightly more than the whole blood. To date, there is still a lot of debate on what concentration is considered ideal or to be therapeutic. There are a few studies that showed up to 1 million platelets per microliter to be considered a therapeutic range, which is approximately 5 times the concentration of normal blood. These platelets contain different granules like alpha granules and dense core granules that contain a host of factors that together have the anti-inflammatory and regenerative properties. When PRP is injected into the joint, so what happens is these growth factors like PDGF, TGF, and others will stimulate the synovium membrane, the synoviocytes that are lining the synovial membrane, to release or increase the production of hyaluronic acid. So this acts as a viscose supplementation. In addition, this PRP, the growth factors that are present within the PRP, also cause proliferation of the osteoblasts through activation of beta-catenin pathway, as you can see here, and suppress the osteoclastic activity by suppressing the binding of RAN-KL ligand to the RAN-K receptor. So ultimately, this leads to decreased osteoclastic activity. That means there's no more remodeling, and increased osteoblast activity, increasing to bone regeneration process. Along with that, the PRP can also do or helps in regeneration of extracellular matrix. And the most important, it has a potent anti-inflammatory effect. So we're gonna a little bit talk about the anti-inflammatory actions of the PRP. So a chondrocyte bear receptors for various cytokines, and one of them, the pro-inflammatory cytokine interleukin-1. So this interleukin-1 receptor, upon binding with the interleukin-1 cytokine, will activate NF-κB and increase the production of matrix metalloproteases, which will further degrade the cartilage. And then when PRP is injected, this PRP will competitively bind the sites of the interleukin receptor and prevents the further downstream pathway where there is decreased or suppression of the release of this matrix metalloproteases. So in addition, there are other pro-inflammatory cytokines like TNF-alpha, which are also inhibited by the TNF-alpha soluble receptors that competitively bind to the receptors and further downstream decreases the production of matrix metalloproteases. As you remember, the PRP not only just have these two factors, there are other factors like other growth factors like TGF-beta, which will directly increase the production of tissue inhibitors of matrix metalloproteases that will directly bind with these matrix metalloproteases and prevent the degradation of chondrocytes. So ultimately, the chondrocyte, the cartilage, is being protected in the first place to undergo further degradation process. So in summary, the PRP protects the cartilage, protects the bone, decrease the inflammation, decrease the subsynovial fluid accumulation, decrease pain, and alters, ultimately the milieu of the inflammatory milieu within the joint, thus causing immediate pain relief and the long-term regenerative effects. So coming to the skeletal muscle injuries, as it in joints, they're also widely used for treating several muscle injuries, which I'm not going to name any specific one, but in general, the mechanism how the PRP functions in the muscle is these growth factors like VEGF, PDGF, they directly activate the satellite cells that are present around these myofibers. These satellite cells basically are like stem cells. Within these satellite cells, these specific transcription factors and these particular genes undergo upregulation after PRP injection. Together, these will enhance muscle regeneration by preventing the apoptosis of these myoblasts, thus help in the regeneration of these myofibers. Besides, it is also shown that the PRP, the growth factors present within the PRP, prevent the fibroblasts to become myofibroblasts, thus preventing the scarring effect that often happens during the resolution of muscle injury. So these are some of the mechanisms that have been widely discussed. It is also shown that, not completely proven, but it also will help in the neural repair process by protecting or nourishing the Schwann cells. Okay, if it is, as it is known, you have seen the molecular mechanisms are well delineated. We know that PRP will have a positive effect by having the pro-inflammatory suppressive effects. But what is the cause for the clinical variation in the clinical outcomes with the PRP? I put together a list here just to give you a perspective, although this is not a comprehensive list. So there is a variability in the PRP preparation methods to start with, and how the blood, what kind of centrifuge you use, and how the blood is being handled. What is the type of PRP that is used? Is it rich or platelet, leukocyte rich or leukocyte poor? Is blood rich or blood poor? And what is the concentration? Is it being activated? And what is the efficacy of the platelet production? And other biological variabilities. And the practice, how the PRP is injected. All together will significantly influence the outcome. Since in the context, I want to bring it up that Dr. Krishna Subramaniam and myself, we are planning to do a clinical trial to understand the role of single nucleotide polymorphisms, which are a type of polymorphisms involving in the variation of single base pair that can significantly alter the outcome of the osteoarthritis. Although majority of these SNPs are not hazardous or harmful to the body, but there are certain SNPs that can alter the outcome in an osteoarthritis patient. So what we are trying to understand is how the stem cell therapy or PRP therapy is affected because of these single nucleotide polymorphisms. So this study, we are in the process of getting the protocols approved, and this is going to get started soon. And also there are other diverse clinical osteoarthritis phenotypes, which I'm not going to the details, also will influence the clinical outcome in a patient that treated with osteoarthritis. So it is not PRP, it is a patient's ability to respond is how the clinical manifestation or clinical outcome can be dependent. Now, coming to cell therapy, mesenchymal stromal cells have been widely used for the last 3 or 4 decades. And, there are stem cells there from bone marrow, adipose tissue, the 2 widely sources, and also umbilical cord is one other source. So these mesenchymal stem cells, a single cell that can replicate itself and differentiate into many cell types. This is the standard definition of a stem cell. But today, this is really not what is happening. This is not how the mesenchymal stem cells actually work in the body. So the way the the stem cells actually work is the release of these growth factors. Again, the circuitome that contain chemokines, growth factors, pro-angiogenic factors, and immunomodulatory factors is how the actual stem cells work. So today we're going to go a little bit detail into how these different growth factors or chemokines that actually modulate the immune system. And some of this research, some of the findings I'm presenting is very recently published. So the regenerative ability of MSC is actually present in our body. Say, for example, when there is an injury, our body responds naturally into that area by migrating these mesenchymal stromal cells from the bone marrow through the blood to the site of the injury. And at the site of injury, they cause cell empowerment by modulating the immune system, causing by releasing of immunosuppressive factors and other growth factors, and causing angiogenesis, etc., and also cause cell replacement. So this is something our body natural ability. That's why when you're young, you have a lot of the stem cells circulating, so your healing process is quick. But as we get old, we need intervention. So that's where the stem cell therapy comes into play. Because as we get older, our bone marrow ability to kick out these mesenchymal stem cells from our bone significantly decreases. So we have to, when these stem cells are given exogenously, what happens is they go to the site of inflammation through a process called as homing. It's just basically a chemokine, it's like a chemotaxis. Once they go to the site of inflammation, there is all these inflammatory cytokines, primarily interferon gamma, TNF alpha, that play a very important role in the activation process of these mesenchymal stem cells or mesenchymal stromal cells. These pro-inflammatory cytokines are released by the T cells, the effector T cells that are present at the site of inflammation. These activated mesenchymal cells, stromal cells, releases some intermediates like IDO, or also called as nitric, which is equivalent to nitric oxide in mouse. So these intermediates and other intermediate called as HLA-G, these will make the effector T cell to undergo apoptosis, and it will activate the monocytes to become M2 macrophages, not M1, M2, which releases anti-inflammatory cytokine like TGF-beta. This TGF-beta, along with the IDO and other chemokine factors, will make these naive T cells to become T regulatory cells, thus causing immunosuppressive effect. And this is how this is all the innate immune effects. It also causes adaptive immune effects by decreasing the proliferation of these B cells that produce these antibodies, and where these antibodies can be deposited in several areas can trigger further inflammation. So the stem cells effectively suppresses the B cell proliferation. So what it is known that if the stem cells are not activated, which means when there is no inflammation in the body, when the stem cells were given, then these stem cells will actually help in the proliferation of the B cells, not suppression. So it is important that our body has is at a very high inflammatory state, and if you give stem cells at the time when there is a good inflammatory state, which is basically you're trying to mimic the natural mechanism. You're timing your stem cell regimen at the time when the body actually needs it, which is actually a natural process, right? When there's injury, you get stem cells. So same thing, you have to assess the patient's need based on the level of inflammation that is present. And then when stem cells are intervened, then there's a very good chance your efficacy of this treatment can be significantly higher. So recent study has shown that the clinical outcome of mesenchymal stem cell therapy is dependent on how the recipient mounts an immune response. So it is not actually the stem cell's fault. It's actually the patient's fault. It's a patient, the recipient ability to mount an immune response will determine the clinical outcome in a patient. So this is a paper that is published in Science, and there's a lot of research going in the area. So basically, this opens up a new window for allogeneic stem cell therapy, because all these days it was thought that the allogeneic stem cell therapy is not good, but no, this will actually change the direction of the allogeneic stem cell therapy. So now, what is the major setback with these stem cell therapies? Is unpredictability, because you can't totally assess how the patient is, what the patient's condition is all the time. So that leaves us with unpredictable outcomes. But then we still pursue, right? Because it is safe, cost effective, with minimal documented side effects, which means there is still a hope that it might still work. So with this, I would like to say thank you all for your attention, and be happy to take any questions.
Dr. Charan, that's a really extraordinary presentation. Understanding the biology of the MSCs and the bone marrow aspirate concentrate, because this particular point has to be understood by all the people who are using, because the moment we give the MSCs or BMAC into the inflammatory state, and how the inflammation is being suppressed as compared to that of the natural one, as if it's we're talking to the adoptive and innate immunity, is really extraordinary the way you explained. Thank you very much. That's my personal comment, and I welcome any other questions about it. I request the audience to ask any questions to Dr. Charan. Dr. Madan, do you want to ask any questions? Dr. Madan?
One
Hello?
question, sir.
Yes, please.
Yeah, please, Madan.
Yeah. Is there any difference between a local injection of mesenchymal stem cell concentrate and intravascular injection?
Dr. Charan, did you get that question? Did you get the question, Dr.
Yes.
Charan?
Can you please repeat that question, Dr. K.S., because I could not really.
Yeah, the question is there any difference?
No, I did not.
The difference of the outcome between the local application of MSCs versus intravascular injection of the MSCs? That's the question. Did you hear the question? Is there any difference in the outcome of a locally injected MSCs versus intravascular injection of MSCs? Am I right? Is that right, Captain Mother? Am I right?
Yeah, yes, sir. Yes, that's the question for me.
Yeah. Lecturing.
Joint space is one area where I would say there might be a big difference when you inject IV versus into the joint, because you already know what your target is, so you're injecting right there. Because so this is what you should really understand. The bigger thing is you're trying to give cells, and your goal is to go to some point of injury, right? When you already know where you already want to inject, so you're already helping the stem cells to go to specific site already. So that's one way of putting together. So another way is the stem cells significantly not only influence the site of injury, it also influences our immune system. We already discussed about that. So that means you're not only having a systemic effects, you also have global effects. So in general, this is Dr. Steve Pelican is in the line. He can also give you some good perspective on this. When the treatment procedure is done here at the Kansas Regenerative Medicine Center, these injections are given at the site of injury and also intravenously, both. So there is a combination where they do like a dose, like a significant dose will go to the site of injury, especially for osteoarthritis, and the remaining will be split into small doses and given IV and other locations as needed. So I don't know, maybe Dr. Pelican can add something more to that because he has done a lot of procedures. So he has more of a clinical understanding of this than I do.
I request Dr. Steve to speak about the same question. Dr. Pelican.
Okay. First, let me thank you for inviting me to be on this webinar. Really appreciate the opportunity to explain my experience with stem cells. I am not a researcher, I'm a clinician, but my experience is that when we first started doing stem cells in the United States at our parent company in California, they were just doing IV and they had some good results. And then my understanding is that, like for instance, if they wanted to inject a knee, they had some damage to a knee, they would just put it in the IV and they had some remarkable results. And then someone thought, well, what if we put the stem cells closer? You have to understand the stem cells are picking up on chemical signaling to follow the chemical signal. And if they thought, well, if we put it closer, the signaling will be a higher concentration and they will follow it. So they injected into the leg and did even better than the IV. And then someone had the idea, well, what if we inject right into the knee? But you have to understand that the three doctors were a cardiologist, a urologist, and a plastic surgeon. So they all said, you injected in the knee. No, you do, because they had no experience how to do that. They eventually got a retired orthopedic doctor to come and inject in the knee. And they had much, much better results. So the theory is, like Dr. Ganta is saying, if you put them close, I think the concentration of the chemical signaling to draw them in is much greater. And that's our experience with many of the different modalities of treatment. And a good example is when we treat stroke patients, we've treated them just with IV with some good results. And then the same patient will come back for a second, third, or fourth. And when we do it intrathecal, we get even better results. So I think it's a matter of making it as easy as possible for the stem cells to hit their targets.
Thank you, Dr. Steve. Thanks for that. I hope, Dr. Madan, you got the answer for that, right? Any other questions? Any other questions? If there are no questions, I thank Dr. Charan for an excellent talk. Now I move to the next talk by Dr. Anil Gautam Manivannan, and let his talk be delivered. Let's all listen to him.
Good evening, everyone. Myself, Dr. Anil Gautam Manivannan, orthopedic surgeon from Coimbatore. Today, we'll be discussing about bone morphogenic protein as a regenerative medicine tool. Bone morphogenic protein are a group of molecules that work by inducing the mesenchymal stem cells to differentiate into bone-forming cell lines that form new bone. BMPs are involved in many physiological and pathological processes such as inflammatory response, bone formation and resorption, growth signaling pathways, and immune response. The two commercially available forms are recombinant BMP2 and recombinant BMP7 that result in endochondral ossification. History of BMP. In 1938, Lavender demonstrated mesenchymal tissue surrounding the graft that is responsible for regeneration of the bone. In 1940, Lecorix named it osteogenic. Later, in 1965, Marshall Urist injected demineralized bone matrix under the skin of rodents that formed a new bone. He coined the term bone morphogenic protein. Later, investigators identified pure variety of proteins that are capable of osteogenesis. BMP became commercially available from 2002. In 2004, US FDA approved the use of recombinant BMP2 in single-level anterior lumbar interbody fusion. The structure of BMP constitutes the largest part of transforming growth factor superfamily, which also comprises actinides and inhibins. Transforming growth factor superfamily is comprised of growth factors and differentiation factors, which have homology in their primary amino acid sequence. Currently, there are about 20 known BMPs available. In bone, BMPs are secreted by osteoprogenitor cells, osteoblasts, and platelets. BMP are synthesized as precursor proteins which contain a hydrophobic leader sequence and propeptides. The biologically active portion is located at the carboxy terminal of the precursor molecule. Active BMP is released by proteolytic removal of the signal peptide at propeptide. The BMP action depends on the target cell type, the maturation pace of target cells, local concentration of BMP, and other biological signals. BMPs are mitogens that stimulate the multiplication of connective tissues as well as morphogens that transform connective cells into osteoprogenitor cells. The several signaling pathways that influence cell division, matrix synthesis, and tissue differentiation. Coming to BMP in bone formation, it induces intramembranous ossification and endochondral ossification that induce osteoclasts that leads to bone resorption. This is a graph that shows broad spectrum usage of BMP for spinal fusion followed by trauma and oral maxillofacial surgeries. This is a graph of US BMP market data that showed extensive use of recombinant BMP2 over recombinant BMP7 and its prediction of steep hike in the increase of its usage in the forthcoming years. Coming to the application of bone morphogenic protein for treating non-union fractures, this is a case of non-union femur fracture that is treated with BMP2 that showed good union by the end of 3 months follow-up. This is another case of non-union femur fracture treated with recombinant BMP2 that showed good cortical by the end of 3 months. This is a case of non-union humerus fracture that is treated with revision internal fixation and BMP infusion that showed good cortical by the end of 3 months follow-up. Coming to treating bone defects with BMP for acetabular bone defects, this is a case of acetabular bone defect with implant failure. He had underwent revision hip arthroplasty with BMP infusion for treating acetabular bone defect that showed good bone formation by the end of 2 months follow-up. Coming to this application in oral and maxillofacial surgery, BMP2 and BMP4 can induce dentin. BMP7 type 1 collagen matrix has shown to promote dentin repair. In dental practice, it is used for fracture healing and mandibular bone defects, alveolar ridge formation, caries, cartilage disc repair in TMJ joint, and dental implants. Coming to its application in spinal instrumentation and fusion, there are around n number of articles that support BMP usage for spinal fusion, though its cost restricts it from usage frequently in our practice. Coming to the advantages, it is a good alternative to autogenous bone graft. Disadvantage being its cost and also the ectopic bone formation that it is found occasionally into the spinal canals that may cause neurological deficit. BMP and cartilage regeneration. There are good evidence that have shown to promote cartilage regeneration with bone morphogenic protein. This is a case of primate study that showed cartilage defect treated with bone morphogenic protein has shown to have good cartilage regeneration and contour by the end of 16 weeks follow. Though further studies are yet to required to use BMP for treating cartilage bone defects. It's a Pandora box that requires further studies and research for its commercial usage in orthopedic practice. These are the two commercially available recombinant BMP that are used for orthopedic surgeries. Thank you.
Thank you very much, Dr. Anil Gautam. I now invite any questions to the lecture. Before that, I have a question. How much volume to be applied for a given fracture? Is there any that kind of study available?
Depends on the size of the
bone defect. Normally for healing long bone fractures, we need at least 8 cc. That costs around 1.6 lakh something. That's commercially available from Medtronic's Infuse. They have it.
Can it be combined with artificial bone matrix? Artificial bone matrix, like we use these days a lot of artificial bone graft substitutes. Can it be added to that, or is there any such contraindication?
There is no such contraindication. If you are planning for the only use of BOP without need for another surgical procedure from bone graft, then no need to expose. That's what I think.
Is there any combination of BMP with bone grafting? Any combination role of BMP along with bone grafting? When we are doing a bone grafting, where is the need for the BMP?
Yeah.
That's my question. That's why I said the role of BMP along with the artificial bone graft or bone graft substitutes.
That I have not used.
Yeah, that's it. Dr. Ravi Sharma, do you have any question?
No.
Now, Dr. Satish has a question you can ask. Satish Kumar has a question.
Yeah, Dr. Anil,
Yes.
what is your experience in atrophic non-unions with the BMP?
The question is role of BMP in atrophic non-unions. Atrophic non-unions.
For long bone fractures, it is good, but
so long bone fractures.
Cases, practically we use for it. So
right. Okay. Has a few experience in very few cases. Any other questions? No. If there are no questions, thank you, Dr. Anil. Thanks for your nice talk. Now we move on to the next lecture by Dr. Tadi Mohan from Kochi. He is going to speak on optimization of the outcomes of viscosupplementation. And now I request his lecture to be delivered.
Good evening, dear friends. I'm Tadi Mohan, clinical professor at Amrita Institute of Medical Sciences in Kochi. And my topic today is optimization of outcomes of viscosupplementation. What is viscosupplementation? It's really the intra-articular injection of synthetic hyaluronic acid derivatives. In short, it's known as IAHA. Mostly we inject the knee joint, but also hip, shoulder, ankle, small joints occasionally. We all know that hyaluronic acid or HA is the main constituent of cartilage and synovial fluid. It has a long polysaccharide chain, glycosaminoglycan chain, which is hydrophilic, and that gives it viscoelastic properties like shock absorption, joint lubrication, and cartilage protection. So IAHA is really synovial fluid restoration therapy. Normal levels of HA are restored. Onset of action is later than steroids, 1 to 4 weeks, but peak effectiveness 5 to 13 weeks, and proven benefit of long lasting of 6 months to 1 year. It has a direct analgesic action in that it blocks nociceptive receptors. It is chondroprotective, antioxidant. It has a mild anti-inflammatory action. Definitely reduces the action, the need for NSAIDs and opioid analgesics. It's easy to use. After all, it's only about once a year injection. It has good tolerance, may delay arthroplasty. So in today's patients whose expectations are vital to their activities, such as early mobility, pain relief, functionality, reversal of disease, and they want to be independent as soon as possible. So you're looking at a local solution for a local problem, and that's where viscosupplementation comes in. If you look at the natural synovial fluid and how it alters in osteoarthritis, you can see that in osteoarthritis there is severe deficiency of hyaluronic acid, both qualitatively and quantitatively, so that what is normal high molecular weight of 6 million Daltons is reduced to 1.45 in osteoarthritis. Normal elasticity of 117 is reduced to 1.9, and normal healthy viscosity of 45 is reduced to 1.4. So abysmal levels. And here is one product which almost matches up to healthy synovial fluid. As you can see here, similar molecular weight, high molecular weight, almost similar elasticity and viscosity. And most of the other products which are sodium hyaluronate do not match up to these numbers. The other thing, interesting thing, is the molecular structure. In most viscosupplements, it's just purified hyaluronan, which is mildly cross-linked, whereas in Synvisc or Hyline GF20, it has two parts to it: a fluid which is Hyline A, a gel which is Hyline B, and both are further cross-linked to give you a highly cross-linked structure, 80%, 20% of that to give Hyline GF20. Another interesting property of synovial fluid is its non-Newtonian property, in that when you walk, it behaves differently, and when you run, it behaves differently. So that in a low frequency movement such as walking, the molecules align, energy is dissipated, it remains viscous. Whereas when you're running high impact, the molecules get entangled, they resist deformation and act as a shock absorber, and energy is stored and not dissipated. Euroviscon in 2018 has recommended that viscosupplementation is appropriate in mild to moderate knee OA, patients who are moderately overweight or normal weight, patients who are inadequately improved by non-pharmacological treatment like braces, physiotherapy, etc., patients who have contraindications to NSAIDs or analgesics, as in cardiac, renal patients, etc. To this, I have also added severe chondromalacia and post-arthroscopy, where I use it in about 4 to 6 weeks after, say, ACL reconstruction, meniscal repair, or osteotomies. Also, it can be given safely in gout, pseudogout, rheumatoid arthritis, and small joint OA. This is a subset of patients unique to sports and high performance athletes, where hyaluronic acid has been injected successfully. Some of the well-known names are Baichung Bhutia in football, Ashish Nehra in cricket, and this NBA player Andrew Bynum, have all benefited. But you have to be careful that viscosupplementation is not tried willy-nilly. So some of the situations where it may fail is high obese patients, severely advanced radiographic OA disease, patellofemoral involvement, large effusions, gross instability, malalignment, and previous failures, and also in sepsis and acute gout. Contralateral knees, 87% show OA changes. So this is a patient of mine. Right side has gross OA, waiting for a total knee replacement. The other one was successfully managed with viscosupplementation. Same here, one knee underwent unicompartmental replacement, the other one underwent a Synvisc injection. So injection can be given in two ways, so the technique is up to you. It can be given with the knee extended, lateral parapatellar route, or with the knee flexed in anterolateral route. So I flex it over a pillow, clean it with betadine spirit, dry it. I use a local anesthetic, 0.5% bupivacaine. What is advised is low concentration, low volume is fine. I give it anterolaterally. A large bore needle is preferable. Steroid is optional. Keep it stored in a refrigerator before you open the sterile pack, and inject it gently without resistance or pain. I advise relative rest after injection. Any adverse effects like local pain, rarely fever can be managed with paracetamol. Frequency is once or twice a year. Tube quantities available in the market, 2 ml and 6 ml. Finally, the take-home message is choose the right visco supplement, choose the right patient, and inject it right. Thank you very much.
Thank you, Dr. Mohan. It's a really simple, crisp, and very informative talk. My only question is, in the present available Indian different types of hyaluronic acid, what do you suggest to the people who start giving this kind of viscotherapy? Is there any particular reason why we should select that? That's what I wanted to know. Hello, Dr. Mohan? Hello? Hello? Dr. Mohan, are you able to hear me? Hello? Dr. Mohan, are you available? All right. If it seems that Dr. Mohan is not available, if that's not the case, if that is the case, I will move on to the next lecture by Dr. Jagbert, the most experienced senior orthopedic surgeon. He is going to speak on non-operative management of knee OA. What should be injected today and in future? Now, I welcome Dr. Jagbert's talk.
It should be pre-recorded. You should have it.
Yeah, it's pre-recorded. Yeah.
Go ahead and run it.
Yeah. Oh, that's okay. But I want his lecture to be next. Dr. Jagbert's lecture. I request Dr. Jagbert's lecture should be relayed. May we have Dr. Jagbert's lecture? May we have Dr. Jagbert's lecture? Yeah. Thank you so much.
Good evening. My name is Jack Burt. I'm going to be talking about non-operative management of osteoarthritis of the knee and what you should be injecting now and in the future. My disclosures are on the Academy website. We have two large databases in the United States. One is termed the United Healthcare Database, and this was published in 2014 in the Journal of Arthroscopy. In patients prior to total knee arthroplasty, about 43% of patients did get intra-articular cortisone, and 15% did receive viscosupplement injections. So about 59% did receive injections prior to total knee replacement. One thing that's fascinating is that there's now an earlier age of onset associated with increased duration of treatment. We used to think back in the 90s, there was only 3 years where you had to treat someone for osteoarthritis of the knee. But we now know that even if you take 10 to 15% of the meniscus out of a 20 to 30-year-old individual, they're going to develop arthritis within 20 to 30 years. So we have a long time of treatment for patients with mild to moderate osteoarthritis. We try to avoid doing total knee replacement in young patients, very simply because the studies show that only about 2/3 of these patients feel pretty good after their total knee. 41% still have stiffness and 33% still have pain. And we also know that only about 80% of patients are satisfied after total knee replacement. So it's very important to try to avoid this as long as possible. And if you look at the limitations of osteoarthritis treatment options, we have at the bottom very poor patient compliance with patients losing weight. About 92% of patients fail their weight loss programs. We also know that exercises don't work very well in patients that are overweight and have degenerative arthrosis. Acetaminophen, we call Tylenol, has a high incidence of hepatotoxicity, in other words, liver failure, up to 4,000 milligrams a day. Non-steroidals such as Motrin, Aleve, ibuprofen, those have a 17 to 19% incidence of gastrointestinal complications. So that puts us up to the upper left-hand corner of the slide, where we start using topical non-steroidal patches, intra-articular cortisone, visco supplements, platelet-rich plasma, and stem cells to try to avoid total knee replacement. And that's what we're going to focus on today. This is an article that I wrote in 2018 with two of my fellows. It has a very good bibliography, and it'll summarize a lot of what I'm going to be speaking about. There's also a very good, article in the Journal of Rheumatology from 2019, which goes through an algorithm of biologics using drugs and also devices like hyaluronic acid, and then the drug device combinations, which is a mixture of both, which is very worthwhile read. So what are the treatment possibilities? We're going to focus on cortisone, platelet-rich plasma, stem cells, and visco supplementation. Now, we know that cortisone blocks the release of prostaglandins, which blocks the release of histamine to reduce inflammation. Zilretta is a long-acting steroid, first came out in November of 2 years ago, consisting of steroids embedded in PLGA, which is the same material we use in Vicryl, a bioabsorbable suture. It's absorbed onto the synovial surface, takes up to 26 weeks to eventually resorb, and it's a wonderful injection, for end-stage osteoarthritis. In other words, when you have bone-on-bone disease. It doesn't do anything but reduce inflammation, but lasts for a long time. If you look at comparing cortisone to hyaluronic acid, at 2 weeks, cortisone works much better. It's about the same at 4 weeks, but then if you look at this study by Juni, which looked at the Cochrane database, a huge database of patients, we know that hyaluronic acid works much better after 8 weeks up to 26 weeks. For those of you who are interested in reading about Zilretta, which should be approved for use in India soon as a long-acting steroid for end-stage disease, Bobick and Conahan have written 2 articles in the Journal of Bone and Joint Surgery. Now, if you were to Google PRP and stem cells, it's amazing how many hits this has hit. I looked this up from June of 2020. PRP was hit 30 million times by patients, stem cells 203 million times. So people are very, very interested in these injectables. Now, the rationale for using platelet-rich plasma is that the use of PRP is that growth factors are released as soon as platelets are activated, with about 70% of them being released within the first 10 minutes after activation. The growth factors have the potential to decrease joint inflammation, decrease the breakdown of cartilage, and increase tissue repair. And this was published in the JBJS reviews this past year. If you look at Feiss's article in the Journal of Arthroscopy on PRP for knee osteoarthrosis, he looked at 27 studies, did show some increased cell viability, decrease in inflammation. However, he concluded that the quality of the literature remained limited by poor methodology and outcome reporting, and future studies must report PRP content, leukocyte poor, leukocyte rich, to achieve relevance. This is a study by Martino that's quoted quite commonly, a level 1 study, 167 patients using high molecular weight visco versus PRP. PRP did not provide an overall superior clinical improvement compared with high molecular weight hyaluronic acid in terms of either symptomatic functional improvement at different follow-up times, or even longevity of the effect or effect duration. And if you look at this study at the JBJS reviews, they drew 3 conclusions. Number 1, intra-articular PRP was labeled inconclusive due to the wide CIs, thus suggesting a considerable uncertainty. Also, intra-articular cortisone, low molecular weight, intra-articular hyaluronic acid were labeled not clinically important. Again, low molecular weight, intra-articular hyaluronic acid. We'll differentiate that just in a minute. But high molecular weight, cross-linked intra-articular hyaluronic acid was labeled clinically important, possibly. Now let's talk about stem cells. Exosomes, which are termed extracellular vesicles, contain growth factors, signaling lipids, messenger RNA. And what they do is they provide cell-to-cell communication. These are very important within stem cells. So stem cells modulate the immune system by releasing these exosomes. secretomes, growth factors, cytokines, chemokines, which are the proteins that are essential in regenerative medicine. So it's really not the mesenchymal stem cell itself, it's these other factors that are contained within the stem cell. So Kaplan made the comment in 2011 that we should change the name of stem cells to medicinal signaling cells, and that's been in the literature now for about the past 9 years. If you look at intra-articular stem cell therapy for the human joint, this study by McIntyre and AJSM is very good. 14 studies, mean follow-up 24 months. All studies did report improvement from baseline in at least one clinical outcome measurement. You can use BMAC, bone marrow aspirate concentrate, Kim study, Shapiro study, some improvement in Kim study, but no differences were seen between BMAC and placebo in Shapiro study, which was published 3 years ago. I think Centino said this pretty well when he looked at a series of 681 patients. There was some slight improvement with lower mean numeric pain scale scores, but he stated that prospective studies to better elucidate the mechanism of action are going to be very important to make certain that bone marrow aspirate concentrate and stem cells are of an advantage. Now, what yields the highest percentage of stem cells? Well, I personally like to use lipid, and this is from Tom Wagner's study, and he showed that adipose tissue or fat is basically where you get the highest concentration of stem cells. So we could take it from the abdomen. We can actually do this in the office, much like liposuction that a plastic surgeon does, or when you're inside the knee, take it from the infrapatellar fat pad. And those are two ways to get the fat. It then gets sonicated after the liposuction. We get these stromal vascular fraction cells derived from fat. And we do know that pain seems to be decreased after therapy. Good manufacturing practices are a problem because there's multiple systems out there for collection, and we clearly need more data, as noted by Subasika this past few months in the Bone Marrow Musculoskeletal Disorders journal. So if you look at the summary of PRP, bone marrow aspirate stromal vascular fraction cells, or lipid, PRP has been shown to decrease pain, inconsistency in studies, methods, responses. There's no significant disease-altering properties that have been noted. BMAC, early clinical outcomes are encouraging. However, low quantities of stem cells are noted. And SVF seems safe and beneficial, but the technique is complex, and there's a lot of systems out there. Now, the truth of the matter is, without the ability to expand and culture stem cells, the success rates of lipid-based stem cells and BMAC are minimally better than PRP or high molecular weight hyaluronic acid. I happened to visit Bogota, Colombia last November, and they do a lot of stem cell culturing and expansion. They get 20 million stem cells from their BMAC and their lipid products. And what's fascinating is we can only get 500,000 to 1 million the way we do it in the US. So that's around the corner. I think it's going to be extremely exciting within the next 3 to 5 years. I'd like to direct the rest of my lecture to why a surgeon should consider viscosupplementation to treat his patients with the osteoarthritis. And the reason is I'd like to discuss some new evidence regarding high molecular weight hyaluronic acid cross-link preparations on patient outcomes. We do know that hyaluronic acid is the major hydrodynamic component of synovial fluid. It's produced by the synoviocytes, which are contained within the joint lining in the synovium. It has a molecular weight of 6 million Daltons in a young individual. It's derived from chicken cones, chicken roosters. There are 3 injectable hyaluronic acids in the US that are cross-linked, and these are the products in the US. We know that Synvisc and Synvisc 1, Gel 1, and Durolane are high molecular weight. There are up to 50 different viscosupplement preparations. I was in Malaysia 2 years ago, and they had 70 different preparations. So there's literally tons of different preparations, and not all of them are very good, and most of them are very low molecular weight. This is the most important slide I'm going to show you tonight. This is a slide showing the molecular weight of healthy young synovial fluid compared to osteoarthritic synovial fluid, what it does in elasticity. Synvisc 1 has very high molecular weight. It's equivalent to young, healthy synovial fluid. Gel 1 is labeled as infinite, and Durolane is about 10 million Daltons. So these are very high molecular weights, which give high elasticity in the joint. The rest of them, very low molecular weight, below 3 million Daltons, and I'll explain why that's important. So it increases the residence time when it's high molecular weight and cross-linked. What that means is it sits in the joint, it resides in the joint to a much longer time frame to exert its positive effects. Again, in synovial fluid, the molecular weight of hyaluronic acid is very low. You get a loss of glycosaminoglycan and cartilage, and that causes that cartilage to get brittle and decreases its resiliency. So what does viscosupplement really do? It does four things. It enhances chondrocyte metabolism, cartilage metabolism, decreases the rate of chondrocyte death or apoptosis. It stimulates the synthesis of your own endogenous hyaluronic acid, and it decreases shear. Now, here's a question I always ask the audience at this point in time in my presentation. The hyaluronic acid molecules in all viscosupplements, are they cross-linked? And the answer is no, not all of them are. Cross-linking increases the residence time, the amount of time it stays in the joint at the hyaluronic acid. The answer to this one is, of course, yes, it does. So cross-linking increases the half-life up to 8.8 days, which can increase the residence time, the amount it stays in the joint, and trace amounts up to 26 weeks. But without the cross-linking, the half-life of viscosupplement compounds can be as short as 3 to 20 hours, and it's out of the body usually within the first 24 hours. And that's why these low molecular weight compounds are very, very useless, quite honestly, for us as orthopedic surgeons. The prolonged residence time does two things. It increases production of the endogenous hyaluronic acid and increases the inhibition of matrix metal proteinases. There are multiple studies that show in a delayed toning arthroplasty when you use high molecular weight cross-linked hyaluronic acid. This is David Waddell's study from Louisiana in the US, published in 2016. 7 years he had out of 1,863 patients. It was delayed by that time frame in over 75% of his case series. Other studies show up to about 15 months. This one is 3.6 years and 182,000 patients for a delay of total knee arthroplasty. But this one is really interesting. This is Nichols' study published last year. The more courses you give of hyaluronic acid, the more it delays the incidence of total knee arthroplasty. So if you only give one hyaluronic acid course, viscosupplement course, 28% had a total knee within 3 years. But if you did as many as 5, only 5% had a total knee within 3 years. So for me, I continue to give it as long as a patient does not wish to have a total knee arthroplasty. And I've been doing this in some patients for up to 13 years every 6 months. Does it slow the progression of cartilage degeneration? Well, there's actually a study that shows that it does. So there must be a biochemical effect. It reduced the degradation of tibial cartilage volume. It stayed the same in those patients that got high molecular weight visco. Those that didn't, the cartilage volume decreased dramatically. Does it result in an increase in the type 2 proteoglycan in the hyaline cartilage cell? Well, in this one study out of University of Pennsylvania, it seems to, by increasing proteoglycan in the superficial cartilage of the patellofemoral joint. So the bottom line is there has to be some biochemical effect that is occurring. Is it useful in the post-arthroscopy patient? So when I see a patient where I'm doing a meniscectomy, has grade 2 and grade 3 changes, I schedule them for a viscosupplement injection about 3 to 4 weeks post-op after their swelling is decreased. And I published 2 articles on this, and it does show in the literature that this decreases pain using this technique, decreases pain upon motion and crepitus in 3 and 6 month follow-ups. So here's the question that always arises when you hear all this information showing how well it works. Why did the Academy of Orthopedic Surgeons come out with such a strong recommendation against its usage? Well, they didn't in 2008, but they reversed themselves in 2013. Why did they do that? Well, they said there was no usage of hyaluronic acid, no usage of arthroscopic debridement. Well, the reason they did it is because they looked at 1,100 studies, only picked out seven that were L1. So they looked at all the studies in the literature and picked only 7. They used MCII and MCID, which I could spend a half an hour describing to you as really being kind of a useless metric for this kind of evaluation. But the bottom line is L1 studies are not always the best study to use. Now, why would I say that? Well, let me give you an example. What if I took everybody in this room and I split you in 2 groups? We went up in an airplane and I said, okay, let's do a prospective randomized trial as to whether parachutes really work. Would you want to be in the group that didn't get a parachute? I don't think so. So at the end of the day, there's problems with L1 studies. We actually wrote an article published in the Journal of Arthroscopy Ravi Bonaru, who's a world-renowned epidemiologist from Tufts, and Lou McIntyre is one of our past presidents of the Arthroscopy Association. And they reviewed all the literature that the Academy looked at to make their decision and found numerous flaws in the way they drew their conclusions. Not only that, they ignored 7 articles written in the past 6 years, which including the recommendation from the Center for Medicare and Medicaid Services, over 65,000 patients, 2 Cochrane meta-analyses. They found no correlation with meaningful clinically important improvement, meaningful clinically important differences, which is what the Academy used. In fact, the effect size was increased in patients who were treated with high molecular weight visco using subjective evaluations, and patient perceptions concluded that of all the conservative approaches, visco was the highest rated treatment. This is a very important study because it points out the fact that when you looked at the randomized studies, and Altman published this in 2016, with a 26-week minimum follow-up, high molecular weight patients, high molecular weight visco supplement patients who had injections with that material had greater efficacy than those that had low molecular weight, less than 3 million Daltons. So that proves that the high molecular weight cross-linked viscos work better based upon the 68 studies in literature. Finally, this is an article from the Journal of Bone and Joint Surgery that was recently published, and it shows high molecular weight and cross-linked formulations are a safe option in patients with knee osteoarthritis. And not only that, what they concluded was that there was a clinically important reduction in pain for younger patients with knee arthritis in those formulations with higher molecular weights or hyaluronic acid cross-linking. That really pretty much puts it in perspective, doesn't it? Finally, what are the patient perceptions of treatment with high molecular weight visco? Well, there's one great study by Posnet out of Europe, 5 different countries, 2,000 patients. And if you look at these 2 charts of all these treatments that the patients got, and they got them all, 66% felt very satisfied, which was the highest response to treatment, and 74% felt visco supplementation, high molecular weight, was most effective of all the treatments in that left-hand column, including prescription oral pain meds, exercises, scopes, narcotics, and steroid injections. The last comment I want to make is regarding economics of care. I know you have to pay, your patients have to pay for these various treatments. And that always raises an ethical question, does it? Should they have a more expensive treatment or one that isn't quite as expensive? Well, I can tell you this for a fact. There are 3 articles written in the United States about high molecular weight visco and its avoidance of total knee arthroplasty. There's something we call quality adjusted life years. This can be as high as $12,800 per year with avoidance of surgery. So what that means is if you keep giving high molecular weight visco every 6 months, you're avoiding a total knee, whether it's 3 years or 7 years or 8 years, at the annualized cost of $12,800 per year. There's also something we call the incremental cost effectiveness ratio. And we believe, based upon these studies, that you save about $38,000 if you use visco instead of doing total knee replacement. So if it costs $300 or $400 for a patient to get it, $700 a year, let's say, the truth of the matter is you're saving at least $12,000 a year by doing that and postponing total knee replacement for the system. So I'm going to draw the following conclusions. High molecular weight cross-linked visco supplement is useful for the treatment of patients with low-grade arthritis or moderate changes of osteoarthritis. And even in patients with some grade 4 changes, I will use it with joint space collapse. And it can postpone total knees by an average in literature of a minimum of 3.8 years, but it's increased with repeat injections up to 7.8 to 8 years. High molecular weight cross-linked visco decreases pain and increases function. Cross-linking of avian-derived visco increases the residence time and improves symptoms up to 26 weeks. The effect size, which is the actual effect it has on a patient, results in a 38% improvement in pain relief in our government Food and Drug Administration sponsored studies, and they approved it. It appears helpful after arthroscopy of the knee when early osteoarthritis is noted at the time of surgery. It's something I do on a regular basis. It appears to decrease existing osteoarthritis progression after injection in a 2-year follow-up. It may increase proteoglycan content of hyaline cartilage after injection. And finally, economically, it reduces the cost per year of osteoarthritis treatment significantly by avoiding total knee arthroplasty. Thank you very much for listening, and I'll take questions at this time.
Thank you very much, Dr. Akbar, for an elaborative talk. I have a quick question. Do you combine Visco with BMAC or PRP?
I have been doing a study, and I've got about 15 patients where I've done PRP with Visco. I'm not seeing a lot of difference using the addition of the PRP white blood cell port with the Visco so far. Now, Brian Cole at Rush has done about 250 patients using a combination. He's in the process of collecting his data. And again, he's not seeing a huge difference.
Right. Then you said grade 4 repeat injections. How often you repeat?
I repeat them every 6 months. I don't use it a lot in grade 4 unless I've run out of options. You're trying to work on the cartilage cell. And the problem is with grade 4 arthritis, there's really no cartilage left. So it acts as a lubricant. Some patients like it if they have a lot of comorbidities, if they're obese, diabetic, cardiac disease. They're not a good candidate for a total knee. They don't want to have a total knee. Then I'll use it. But the success rates, if you look at the literature, drop down to close to 20% in grade 4s. In grade 2 and 3 is up to that 65 to 72% range. So it's not terribly successful in patients with a complete joint space collapse.
And then in your talk, you have mentioned about exosomes. Can you elaborate a bit about that? Because that's a future.
Yeah, I think you're right. These extracellular vesicles and the whole concept of mesenchymal stem cells are just fascinating. We've, Kaplan has been talking about this, not really for 9 years. I misspoke. It's more like 29 years. And so I really believe that if we can culture and expand stem cells, it's going to be a huge, huge difference. In Colombia, when I visited there, they're using it for Alzheimer's disease, injectable stem cells. They're getting closest to 25 to 30% improvement in Alzheimer's. Their cartilage biopsy cells look nothing like mine in patients who've had stem cells. They're much more exuberant with much better quality cartilage. So I agree with you. I think that's going to be the future. But for at least in our country, it's a good 5 years away.
Right. Thank you. Last question from me. Do you activate the PRP before giving or don't?
I do not.
Thank you. I welcome any other questions. Any more questions?
One question. Was it not the economic factor which is actually what made them reverse the decision in 2015, Dr. Burt, that they felt that $38,000 or $40,000 extra on someone who might have otherwise needed a knee replacement? In reading through that, a brief of that report, I thought they felt that a cost of around $12,000 per year was one of the reasons they felt that it's an addition of 30,000 or 40,000 to the system when you're delaying the knee replacement. That was my understanding. I don't know.
Yeah, so that's a great question. No, the truth of the matter is I personally, I pay $500 for any of the high molecular weight cross-linked viscos in my office. Some are as low as $450. We only are allowed to inject them 2 times per year because that's all insurance coverage will allow. So the annualized cost plus my injectable cost of $60 is never more than $1,100 per year. I have appeared before that a committee on over 5 different occasions. They are absolutely locked into the concept that they've got to use these level 1 studies. We're having a battle with them right now to try to get them to exempt high molecular weight cross-linked visco from the remainder of the viscos. We think we got about an 80% chance of getting that done. Unfortunately, COVID, like in your country, has taken over everything. And so none of the committees are meeting. They're trying to do it virtually, but they haven't been very successful. So we think we're going to have an answer by next year as to whether or not they're going to allow insurance companies and give a somewhat non-committal approach to whether visco is useful. But if they look at the recent literature, there's no question it helps. And we're trying to convince them that that's the case.
Because even
It's all political.
Yes, even in England or UK, they're trying not to use that much. It's because of the same reason, because we all know it is effective and also patient satisfaction is there. But that's why you wouldn't find many studies coming from England, or you will have from other European countries, but not necessarily from England.
Yeah, no, the Posnet study is based out of England. It's a great study showing the effectiveness, and it's so frustrating because they won't listen. And you know as well as I do how many patients get benefited by it, and you save them from going through a very painful operation. Very frustrating.
Any more questions?
Question. Just wanted to congratulate Dr. Burt on a wonderful presentation. Taking on what was being discussed, NHS actually uses Synvisc regularly to delay, their replacements. I mean, patients who are on the waiting list routinely get Synvisc, during the interim period. That keeps them happy. It keeps them going for some time. And I've been seeing that for several years, and that was how I was introduced to Synvisc, in the beginning. So I'm not surprised. I mean, after coming back to India also, I've been using it quite a bit, and it has helped me in so many situations. So the American Academy report came as a bit of a surprise to me, because whichever surgeon I've actually spoken to who use Synvisc regularly, they have had only positive, feedback. So I was a bit surprised, and then of course it turns out they were not really studying all the visco supplementations. They are mixing both the low molecular weight, high molecular weight preparations, and then that's why you are getting a skewed result.
That's exactly right, because the literature mixes all the molecular weights together, and then the low molecular weights give very poor results. It's no better than saline. And so that's why you're precisely right. That's why the conclusions are drawn the way they're drawn.
Exactly.
So Dr. Burt, I have a quick question for you. So when we're talking about these comparative studies between with PRP or BMAC or SVF or PR and visco supplementation, there are a lot of other studies out there comparing PRP with visco supplementation. So again, for PRP, I know there's an inherent problem because people do not actually describe what kind of PRP they're using. There are a lot of other inconsistencies with the PRP. I understand that part. But again, there is literature that strongly supports the positive outcomes with PRP as compared to hyaluronic acid injections. Because PRP actually addresses the natural healing mechanism right from the foundation. And visco supplementation are actually providing something from the outside. So there is science that shows why and why not. But from your experience, I'd like you to comment on the comparative studies that were done out there, published out there. So why people see that, hey, PRP is better than visco supplementation, and you say there's no significant difference. I'd like to see why there is such much discrepancy.
Well, again, I think that several of the studies that I could quote to you do not use high molecular weight as a comparative tool. But I'm very intrigued by the work that's going on by John Kelly at the University of Pennsylvania, who has shown that you increase the amount of type 2 proteoglycan in the cartilage cell with high molecular weight visco supplementation. And you're absolutely correct. There's a lot of differentiators that occur once the activation of PRP occurs, which can suppress the cytokines, for example. But visco will do the same thing. And so again, it's a very difficult comparison because of the chosen hyaluronic acid that's used for the comparative purposes. For example, if you look at the Italian literature by Elisabetta Kahn, she will show a series of studies that shows that high molecular weight will beat PRP every time. Whereas if you go to the West Coast of the United States, it's just the opposite. But again, they're using a different type of PRP preparation and a different type of viscosupplement preparation. So I think that's why the literature is so confusing, because we haven't been able to localize it to specific types of PRP and specific types of viscosupplementation, because there's multiple PRPs out in the US. There's over 7 that I know of. And as you're aware, there's virtually a dozen different viscos.
Right, I agree.
Thank you. Thank you very much, Dr. Akpat and others. Now we're coming to the panel discussion. The moderator will be Dr. Somsekhar Reddy, my very good friend. And the panelists will be Dr. Jagbert from Paris, Kiran Acharya from Manipal, Dr. Sharma from Vizag, and Dr. Kosigan from Chennai Airport. I request Dr. Somsekhar to speak.
Hello, namaste. Welcome to the panel discussion on case presentations. And I'm Somsekhar Reddy, and I would like to welcome my panel and introduce the members, Dr. Kiran Acharya, from United States, Dr. Kiran Acharya from Manipur, and Dr. Ravi Sharma from Vizag, and Dr. Kosigan from Chennai. Now, next slide, please. Now, we have been using viscosupplementation for most of the standard indications. But from time to time, we may get some patients where we don't have any alternative because we got a patient with certain situation and we don't really have any specific treatment which can help the patient. So in those cases, we may have to extend the use of viscosupplementation, and sometimes it may be off-label. So I'm going to present 3 cases for you, which were collected from South India, from different surgeons, 3 cases from different surgeons. And I'll show you, and I request the opinion of the learned panel and any questions from the participants. Next one, please.
Sir, good afternoon.
Good afternoon, sir.
How long have you had knee pain, sir?
Pain on both sides of the leg and more so on the right side.
Sir, did you get TKR done?
I met doctor 5 years ago and wanted TKR to be done on both legs. Doctor suggested that TKR can be done on the right side. On the left side, oil injection can be given.
Sir, after the injection, when did you get pain relief?
Got relief pain 3 weeks after the injection and got relief up to 10 to 11 months.
Sir, how do you know that the injection stopped working?
I got mild discomfort at the end of the year and stiffness I found it, and I got the injection done again. Each time it is working for 1 year for the last 6 years. Due to corona, I got delayed to take the injection, and during that period I suffered severe pain. I got the injection.
Next slide, please. Now, these are the questions I would like an opinion from the panel, like how many times intra-articular hyaluronic acid can be given, how long is the response, and if somebody doesn't respond, when can we give, when can we try again, and each time how long it may work, and if somebody wants to postpone their TKR, will it help to postpone? And if it is postponing, is it like a placebo effect or analgesic effect or a biologic effect? I think we had some discussion on these points already. Maybe I'm repeating the questions. It came. Next slide, please. Next slide.
Complaint for which
No, sorry, back. Back, please. Yeah, sorry. And the questions again, please.
Sir, good afternoon.
Yeah, next slide. Yeah. Now I would like to ask Dr. Kiran Acharya about his opinion on these questions.
ideally one needs to reassess the patient after his symptoms reappear, because we need to take a call whether any mechanical factors have cropped up in the waiting time, not blindly injecting every time. After reassessment, if you can't find anything new, yes, you can inject at the end of roughly 12 to 18 months or at the onset of symptoms. In my personal experience, I have injected about 8 times for a particular patient. And how long one should wait? It's about 12 to 18 months. And someone doesn't respond to IHA, I will always ask a question, what was injected to him in the first instance? And then the high molecular weight can still, still has an option. And we always take an audit when the patient has not intra-articular hyaluronic acid injection on 3 counts. One, whether what was given. Second, I need to clinically reassess the patient and also do the radiological. How long the release? Usually 18 months for most patients. Some patients have come back even after 4 years because they were lost for follow and they were very happy with the injection. They came back at 4 years. And the last question, if a patient was advised TKR and wants to delay by a few months due to some reasons, one cannot exactly say what action, but lubricant effect with the anti-inflammatory action provides pain relief to the patient. Ultimately, he benefits when the literature suggests that.
Okay, thank you. I think you covered those things, and the same thing from Dr. Jack Butt, I think, which you may be repeating, which you just answered. Anyway, kindly go ahead, please.
Yeah, very quickly, I would agree regarding to reassess it, but I've got to tell you, I have got some patients that are in their 40s that I'm injecting every 6 months for the last 13 to 14 years. And the reason is, I would ask the panelists, what do you do with somebody that's 35, 45, 55 years old that has grade 2 and grade 3 changes, and you want to postpone having a total knee as long as possible? So my response to that, if I were to be asked that question, is I'm trying to build up the proteoglycan in the cartilage cell. I'm trying to keep the tibial cartilage from decreasing based upon the Wang study. So I will literally inject these patients based upon the literature showing that it has some effect for 26 weeks. And sure, it can last longer, but it seems to have a compound effect if you look at the Nichols study by doing it every 6 months indefinitely. So I literally will keep doing this until the patient is dead. I know that sounds strange, but I would ask the question, what else can you do for these people except utilize high molecular weight visco, potentially PRP, potentially stem cells if they get better? So for me, that's the response to that particular question.
Thank you. And Dr. Kosigan, please. Hello, Dr. Kosigan, please.
When he's about to respond, let me just make a quick comment. Most of my observations came from citing Prof. Jack Butt from the last decade. In most of my presentation, I have been citing him. It's good to see him face to face today.
Good. Okay, Dr. Ravi Sharma. Ravi Sharma, unmute.
Yeah, I usually give. I'm audible. Am I
Yeah,
audible?
now okay. Yeah.
Hello. Yeah.
Yeah.
Yeah. Usually, I give hyaluronic acid every year, given 4 doses for a single patient, and some people usually don't turn enough. So I usually wait for at least 3 to 4 weeks for the effect of the injection to come up. So 3 to 4 weeks is the time. Until 3 to 4 weeks, patients usually come up with even a flare up of the pain. So usually you have to wait for 3 to 4 weeks. And if someone doesn't respond well, does repeat injection help? Well, I don't. If the patient doesn't respond to the, especially I usually give only the high molecular weight, this Siniscon only. So there is no question of a second if it doesn't respond well to the first one. And in my about so far experience, the from That is the longest weeks, and usually they turn up at 12 months or 18 months. And if the patient was advised TKR and he wants to delay it by just a few months, I don't give a hyaluronic acid, because I feel it's more of a biological response than an analgesic. So to a few months, there is no role of a hyaluronic acid.
Okay, perhaps then you may try a steroid. Okay, anyway, thank you very much. Can we go to the next slide, please?
What was the complaint for which you wanted to have the injection for the shoulder?
Mainly shoulder, because I had some sort of pain from here, so I can't.
You couldn't move it.
Slowly I started doing it.
For the giving the injection, what was your movement like?
Movement was very poor.
After we gave the injection, what was the pain relief?
Pain was very good.
Very good. And how many days following this injection did you have the pain relief? Immediately, or did it take
Some time back.
sometime? Are you able to now move your shoulder much?
Yeah.
You can move it very much. Yeah. Can you do your daily activities with the shoulder?
Shoulder I can do all the
All activities. Good. And for following the injection, you have improved.
better.
Very better. Okay.
Okay, now again, may I request opinion from the panel? Again, starting with Dr. Kiran Acharya, please.
I have a very limited experience of injecting hyaluronic acid into the shoulders, though I must admit that I have injected in some cases. And most of these patients were the ones who came back with a dry joint feel following shoulder arthroscopy, and they did very well. And we also routinely do surgical management of adhesive capsulitis. Those cases, some of them who had a glenohumeral arthritis, they did receive injections post-operatively. And we always do the shoulder injection ultrasound guided. So these are my observations. And I should say, with the numbers I have in this regard, evidence is mostly anecdotal.
Ultrasound guided into the glenohumeral joint or subacromial space?
Into the glenohumeral.
Thank you. And Dr. Jagbhat, please.
Yeah, there's a real good study out of the Journal of Shoulder and Elbow Surgery by Zhang, Z-H-A-N-G, this past year, which is kind of ironic because the Academy actually says it does seem to help in a non-committal fashion in the shoulder. So I've done maybe 20 of these is all. I don't have a tremendous experience, but I've got to tell you, if you do it under ultrasound or fluoro in a stiff shoulder with the manipulation, or I'll scope the shoulder to a capsulorrhaphy, then wait a couple weeks and then inject it under fluoro or under ultrasound, these patients seem to do pretty well. And like I said, there's some support. There's actually two studies. There's Zhang in 2019, and I think it's ZWONG in 2013, which does show a significant amount of improvement. So I will use it after manipulation versus a capsulotomy or capsulorrhaphy arthroscopically. Wait a few weeks like I do with any other type of arthroscopy before I inject visco. And I've had some improvement. And again, I don't have a tremendous experience in it, but the literature seems pretty clear that it does help.
So given the choice, if the patient doesn't object, you would like to help him with the hyaluronic viscosupplement into the shoulder.
Yes, and I would not inject into the subacromial space. It would definitely be in the glenohumeral joint.
Thank you. And Dr. Kosigan, please. Okay, Dr. Ravi Sharma, are you here?
Yeah, I'm here. So I feel there is no role for IHA in rotator cuff tendinitis, but stiff shoulders, I give it as a last choice, because initially physiotherapy, all this, if everything fails, hyaluronic acid works. And I wait for 3 weeks following a manipulation and then give hyaluronic acid injection. And glenohumeral osteoarthritis, I have given injection into the glenohumeral joint, and the relief was really good. And some of the patients are, hello? Am I audible?
Yeah, okay, go ahead. Yeah,
So,
anyway,
osteoarthritis and rotator cuff arthropathy.
Yeah.
Both of them, definitely it is useful.
Okay, thank you. I think the panel seem to agree that the injection should be given into the glenohumeral joint. Definitely there is a role in the stiff joints, and if we are manipulating, better for the tissues to heal for 2 to 3 weeks time before giving injection, and the injection ideally should be given under either CM control or an ultrasound guided needle. Okay, that's very uniform. Thank you. And the next slide, please. Right. Here is a person who had a ACL reconstruction about 2 years ago. Unfortunately, developed stiffness. He is not happy, and then the surgeon decided after some time with like debridement with viscosupplementation and physiotherapy, and the patient ultimately got reasonably good result. Next slide, please. Yeah, these are the questions now. Again, we'll start from the bottom. Dr. Ravi Sharma.
Whether I use regularly for all ACL reconstructions? No. During arthroscopy, if I find any chondral damage, definitely at the end of 4 weeks post-operatively, I give hyaluronic acid injection. Multi-ligament reconstructions, I have no experience, but if there is an articular cartilage damage, yes, I give it. And even in revision case,
would you change from a normal person to a sports person? Your indications change in a ligament reconstruction for a sports person, ligament reconstruction for a normal household person?
No, the indications remain the same. That for during arthroscopy, if I find chondral damage, definitely I give it. Anybody.
And do you think it has any role in preventing or helping patients with arthrofibrosis post-reconstruction?
Well, I don't have any experience for post-revision reconstructions and no. Normal reconstruction with arthrofibrosis, yes.
So for arthrofibrosis, you think there is a role?
Yes, yes.
Okay. And Dr. Kosigan, please. Dr. Kosigan? Okay. Dr. Kiran?
Per se, I would assess the causes for stiffness following ACL reconstruction first. It could be a poor rehabilitation. And if the knee is really stiff, it would definitely require a MRI to look for any pathology. If rehab doesn't work, if patient doesn't have inflammatory changes, it would always be good to do a relook arthroscopy to do the edestycholysis. Only at the end of 1 more month following the second procedure, I would go for a viscosupplementation if I had seen the cartilage damage during the primary procedure. And only if there is concomitant cartilage lesions, yes, it would be advisable. And in sports persons, invariably, there is up to 65% chance of finding a cartilage lesion, especially in the patellofemoral as well. Most of the time, we tend to forget the patellofemoral when we do the ACL reconstructions. And in my opinion, the best response is always 4 to 6 months following arthroscopic ACL reconstruction, the injection should be done. And patients who undergo viscosupplementation following ACL reconstruction, they seem to have better functional outcome compared to those who do not. Because we have a set of patients who refuse the injection, even though they had a cartilage lesion when we did the ACL reconstruction, they do not wish to take the injection. And when we compare those subset, we realize those who received the injection did better at the end, usually at the end of 3 months, their functional outcome is very good.
Sometimes the recommendation is that you can give after 2 weeks after an arthroscopy. Is there any reason for delaying up to 3 months?
It's mostly my ACL protocol and also study by Wong, which very clearly he did immediate post-op 1 week, 2 weeks, 4 weeks. He found best results at 4 to 8 weeks. And my ACL protocol says that after you do surgery, patient goes home, gets the sutures removed in his hometown. He comes back to me at the end of 1 month. And when he comes for review at the end of 1 month for change of rehabilitation protocol, that's the best time I can reassess his movements and also give the injection. It's been working well.
You did mention about patellofemoral changes during arthroscopy, but generally viscosupplements are supposed to be better for the main tibiofemoral joint rather than patellofemoral joint. But you seem to get good result even in patellofemoral joint cartilage lesions.
Yes, majority of my patients who have been receiving viscosupplementation had predominantly patellofemoral, and most of them post-arthroscopy cases especially. We have done the radiofrequency coablation of the patellofemoral arthritis, and at the end of 1 month, they received the viscosupplementation. In India, because of the habit of kneeling, sitting cross-legged, squatting, and climbing stairs repeatedly without lift, and all these things add to the burden. And remember, most of the patients point to the front of the knee when they come to you.
Sure. Thank you. And Dr. Jagbhat, please.
Yeah, I think that those are really great comments. The Wong study is something everyone should remember, that you really should wait 3 to 4 weeks before you do the injectable. Number two is, I would totally agree with the speaker about not doing it just because it's an ACL. You've got to have cartilage damage. There's absolutely no sense in injecting high molecular weight visco in someone without cartilage damage. It won't have any effect. And number three, what hasn't been mentioned is I see a lot of patients from a significant distance away, and sometimes you have a professional athlete that'll come to see you, and then you'll get a call after you inject the visco 6 hours later, 12 hours later, that, gee, my knee's swollen, I'm going to the emergency room. Everyone should remember there's a 2 to 6% incidence of pseudosepsis. And we think that's caused, by the way, from having an extra amount of protein, 7.1 micrograms per millimeter of protein in Synvisc. And so what happens sometimes, you get these pseudosepses and the patients blow up like a balloon, and they go to the emergency room, they get aspirated, they see some cloudy material, and they think they're infected. Well, over the last 20 years, I've had 4 of those. Those can be treated with oral steroids, or what I normally do with patients who come from a distance is I'll inject 1 cc of Celestone or Depomedrol in the 6 cc syringe and then inject the patient. And there's 2 studies, one by DeCampos, one by Briggs, and I've got a series of 300 myself with 0 incidence of pseudosepsis. There's been a study out of Baton Rouge by Dr. Waddell that shows if you don't add more than 1 cc of steroid to the 6 cc's of Synvisc, it will not degrade the high molecular weight visco. If you add 2 or 3 cc's, it can, and these are all animal studies. So just for the sake of a word to the wise, if you will, don't be afraid to add a cc of cortisone to that visco supplement if you're seeing a patient that you can't see regularly, or is from out of town, or you want to sleep at night and not have to go into the emergency room. So I do it very frequently.
Thank you. In your response, you did mention about pseudosepsis and the technique how you inject also, but due to the time constraint, I was not able to include that one. And I thank all my panel members for taking part in this small case discussion. And I would thank for your valuable inputs and your opinions, which definitely will help us our practice. Thank you.
Thank you very much.
Thank you, Dr. Somshekhar, for a wonderful panel discussion. I personally thank all the panelists. Now that comes to the end of the session 1. Now we are moving to the session 2. The first lecture in the session 2 is by Dr. Madan Jayaraman. He is presently working in Shada University, and he is pursuing his PhD, and he is going to speak on the decoding adipose tissue derived stem cells in ONE and the role of BMAC versus stromal vascular factor in ONEs. Dr. Madan Jayaraman, I welcome you.
Very good evening. I'm Dr. Madan Jayaraman from Shada University, New Delhi. I'm here to present on the topic decoding adipose tissue derived stem cells in osteoarthritis knee and the role of bone marrow aspirate concentrate versus SVF in osteoarthritis knee. The hypothesis of osteoarthritis knee relies upon rate of cartilage degeneration versus rate of cartilage repair. The cartilage degeneration is because of interleukin-1, which is a pro-inflammatory molecule, which further degenerates the cartilage matrix and extracellular matrix in the articular cartilage. Hence, the degeneration results. So here comes the concept of orthobiologics. The basis of orthobiologics are coined by World Orthobiologic Forum and a regenerative orthobiologist, which comprises of matrix materials, growth factors, and stem cells. All these three components, if it works in a coordinated environment, which leads to regenerative homeostasis. So the concept of cellular therapy deals with transplantation of human cells to replace or repair the damaged tissue or the cells. What cellular therapy offers? It improves the quality structure of the regenerated part, and it increases the biomechanical strength of the tissue regeneration and healing process, and it hastens the recovery. So International Society for Cellular Therapy has laid the criteria. Whenever a cell is being transplanted to the area of interest, the transplanted cell should be able to form cellular components of trilemmates, that is osteogenesis, adipogenesis, and chondrogenesis. When the same transplanted cell is cultured or co-cultured with other cells, it should be able to produce plastic-like fibroblastic morphology. And when tested for immunohistochemistry markers, it should at least show 13 cluster differentiation 13, 73, 90, and 105. So orthopedic surgeons and regenerative orthobiologists are concerned about adipose tissue because of its abundance, ease of collection, and the heterogeneity of stem cells. Once adipose tissue is derived, and it should be processed for the products. The products are as follows. These are macro and microfat, nanofat, microvascular fragments, stromal vascular fraction, adipose stem cells, microsomes, exosomes, and secretomes. So this adipose stem cells can be converted into sheets called adipose stem cell sheets and adipose stem cell spheroids. Adipose stem cells can be placed along with the scaffolds for the carrier molecule. So stromal vascular fraction is nothing but it's a collection of heterogeneous population of cells which contains mesenchymal stem cells, pre-adipocytes, pericytes, and progenitor cells. So it is nothing but a heterogeneous population of various cells, and because of a collection of cells, the allogenic usage is very questionable because of very diverse immunogenicity. Since it is multipotent in origin, it has multi-differentiating potential. It renders immunomodulation, anti-inflammation, trophicity, and regenerative potential. So it possesses the cell surface antigens of hematopoietic stem cells as well as mesenchymal stem cells. Though SVF is from adipose tissue derived stem cells, it shares the common cell surface antigens of bone marrow derived mesenchymal stem cells. And once in doubling cultures, it possesses cluster differentiation 34, which is the hematopoietic stem cell marker. And pericyte is very important among all the components because pericyte renders regenerative potential. So the immunomodulation is with three mechanisms. One is via interleukin-6 through neutrophil, and macrophage 0 through macrophage 0 via dendritic cell 1 and 2 through soluble HLA G5 via T regulator cells. So preparation, we have enzymatic digestion and the mechanical preparation. Enzymatic digestion involves addition of collagenase 1 and 3 enzyme. The final product SVF renders more number of cellular components in resultant SVF. But in mechanical degeneration or disintegration, we have to condense the lipids, and we will disintegrate via liver lock injectors to convert macrofat into microfat and microfat into nanofat, and further nanofat will be passed in passes and subjected for centrifugation. The resultant product is stromal vascular fraction. Along with the stromal cell solution and stromal cell aggregate, it is called total stromal fraction. So it is delivered via direct delivery or cell-based delivery. Direct delivery, once cell is identified and concentrated, it should be transferred to the area of interest. Cell-based delivery, it will be in vitro culture will be done and it has to be transplanted to the area of interest. So in India, cell-based delivery is possible only for regeneration of liver and kidneys. So SPF and ONE, SPF is the perfect cell-based product for osteoarthritis knee in regenerating the cartilage, and this SPF provides a balance between pro and anti-inflammatory, apoptotic and angiogenic factors. So this SBF contains mesenchymal stromal cells or like cells which upregulates tissue inhibitor matrix metalloproteinase by downregulating the matrix metalloproteinase, and hence it leads to the joint homeostasis. In this regards, in SBF will lead to regenerative homeostasis. So the picture depicts the same. A study published in 2019 where SBF therapy has been advocated for more than 80 years of age in grade 2 to 4 of Kellgren-Lawrence scoring. They concluded more than 15 into 10 power 6 SBF cells will give long-lasting effect. A study published in 2020, April 6, suggested that grade 2 has good functional outcome by WOMAC score than grade 3 and grade 4. It is a short-term study for 12 months follow-up. And one more study published in April 9, 2020, which suggested there is a micromolecular mimicry between infrapatellar fat pad and SBF, where SBF re-educates the infrapatellar fat pad and controls the interleukin 1, and it renders interleukin 1 into interleukin 1 receptor antagonist. Hence, there is a homeostatic, protective, and anti-inflammatory environment there. Myself and my colleagues have conducted a meta-analysis, and we observed that adipose-derived stem cells gives mesenchymal stem cells yield of 500 times more than bone marrow stem cells, but bone marrow stem cells gives a better cartilage regeneration than adipose tissue stem cells. Since because adipose tissue stem cells is a heterogeneous population of cells, that is stromal vascular fraction contains more growth factors and cytokines, it is possible and it is potential to regrow the cartilage and regenerate the cartilage. So we finally concluded that the efficacy, safety, and superiority of adipose-derived mesenchymal stem cells compared to bone marrow stem cells in the management of osteoarthritis knee. So cellular therapy in osteoarthritis knee relies upon dosage has to be standardized, frequency has to be standardized, protocol has to be universalized, and the amount of growth factors in that MSC cocktail should be quantified. Either it relies on whether we are using autologous or allogeneic formulation, and the main important thing is we are concerned about cartilage regeneration. So radiological documentation, that is MR cardiogram, has to be taken pre and post injection to validate the same. And finally, we have to conduct randomized clinical trials for BMAC and SBF in osteoarthritis knee to validate the findings. Thank you.
Thank you, Dr. Madan Jayaraman. I have a quick question. You said from the bone marrow derived stem cells compared to adipose tissue. In adipose tissue, MSCs are almost 500-fold. But did you quantify the expression of the CD antigen, both positive and negative in both the things? Is it available in the literature?
Sir, actually, in my PhD, I have started 5 cases in both. So I have stored that BMAC and SBF, what I have collected, I have stored in a lab. So we have a tie-up with one lab to be quantified the findings, how much amount of stem cells are there. SBF is basically a collection of cells. So we have to quantify the number of cells rather than number of what cells is there, because we cannot differentiate once we started counting the cells, we cannot differentiate either it is a pre-adipocyte or a adipoblast or progenitor cell. So we will just calculate the number of cells. So they are designing how to count the number of cells in SBF. But BMAC, we have counted the cell. It is showing 5 million cells.
No, my question is no. My question is, yes, I'm not talking about the quantity of the cells. It is available, but the expression of the CD antigens, both positive expression, negative expression of the given microliter, given number of cells per microliter. Why BMAC has scored a better regrow potential, though the number of cells are less as compared to adipose, is because of the positive expression of the CD antigens from BMAC compared to adipose. That's what my understanding. Can you comment on that?
So that CD antigens for SBF we have not done till now, but BMAC though we have done. But it is my further PhD work which I will carry out CD antigens markers both positive and negative. Right. But till now I have not done. I will do it later.
Yeah, please go through that. That is going to change the concept of the future therapy. The
Sure,
CD
sir.
expression of the CD positive antigens in the given cell is the one that is more important for the quality of the regenerative therapy by the given BMAC or adipose derived stem cells.
Sure, sir. That I'll take into consideration
Thank
for
you.
my
Please.
PhD. Thank you, sir.
Thank you.
So, Dr. Kriyas, I
Sir.
just want to quickly comment on thing.
Yeah.
We actually have done that study already here,
Sir.
and not in the comparative method, but we took the SVF, we did the, CD marker expression, and I have the data. We did not publish it because we are just trying to understand how many of these are actually present. But again, the best assay, again, this is for you, Dr. Jairam, for you
Yes,
to
sir.
consider for your PhD. The best way for you to actually evaluate how many MSCs are present in your SVF is by doing a colony forming unit assay, CFU assay. So you
Okay, sir.
actually
I will
take
consider.
your SVF and you plate it in a media where you can grow individual colonies. That means you need to dilute your SVF and then plate them. When you plate
Yes, sir.
them, they grow in small groups. So that
Sure,
will
sir.
so you can count actually how many real MSCs that are present in your SVF. And that use
Okay,
the
sir.
same method to compare with the BMAC. So you can kind of do like apples to apples comparison.
Sure, sir. I will consider this point as well, sir.
Yeah. I mean, I already have the data and I'll be happy to share that if you think that will help with your PhD.
Sure, sir. Sure, sir.
Thank you, Dr. Charan, for that comment. Any other questions on this particular subject? If there are no questions, I quickly move on to the next talk of the second session. Sorry?
One more question, Dr.
Yeah.
K.S.
Yeah, please.
This is again for Dr. Jairam. What is the current guidelines for uses of SVF in India?
Sir,
What is ICMR guidelines for use of SVF?
Sir, ICMR, it is more than, it will come under more than minimally manipulative, sir.
Sure,
So,
yeah.
yes, and moreover, I am not using any collagenase enzyme to extract SVF. I am doing only mechanical method.
Oh, okay, just like lipogems.
Yes, sir. Yes, sir. Lipocubes, lipogems. I'm using T-Lab kits, T-Lab microlyzer kit and liver lock injectors, sir.
Okay,
That's
sounds
good.
good. Thank you.
Thank you. Thank you, Dr. Raman. Now I move to the second lecture of the session. Core decompression with BMAC and BMAC supplementation, a regenerative plausibility in avian hips by Dr. Satish Muthu. Now, may I have the...
Very good afternoon to all the viewers of this VSSCon 2020 virtual conference. I'm here to talk about core decompression with bone marrow aspiration concentrate as a regenerative plausibility in osteonecrosis of femur head. We'll just jump into the flow in which that talk will be given. First, we will talk about the evolution, how the treatment has been devised, and the evidences supporting the treatment, and we'll have a discussion on the methodologies and the treatment aspects. Osteonecrosis of femur head is the leading cause of arthroplasty in young adults. And despite treating this condition for decades, orthopedic surgeons have only able to treat the effect of the disease and could not able to prevent or find a remedy for the disease pathology. And hence the primary surgical treatment for this disease remains core decompression. So how the treatment came into effect is just because of an accidental improvement of the patients who underwent biopsy of this osteonecrosis by Fickett and Arlett, and hence they devised this as a treatment method to manage the cases with osteonecrosis of femur head, and consider it as a joint preserving procedure for all the early stages of coin. Later, David Hungerford propagated and popularized this technique in the US by founding the Center for Osteonecrosis Education and Research in Johns Hopkins University. And across his various studies, he found that a success rate of 65% for the people who were undergoing this core decompression compared to that of non-operative treatment which was being propagated earlier. The core decompression was initially performed with 6 to 8 mm hollow trephines, which was...
So I'm going to talk about using the GraftNet for osteochondral defect of the knee. Unfortunately, because of the lockdown and patients who came after that.
Converted to either a single or multiple track of drills that refines of varying diameters. Compared to other surgical modalities such as rotational osteotomy, which manages only the biomechanical component of the effect of the disease, co-decompression as a main surgical option is being approved in various centers and is significantly outperforming the other surgical procedures also. There are limitations to this surgical procedure because only 65% success rate is being recorded, and many surgeons focus their research towards improving the success rate and potential of treating these cases. So then came the landmark paper by Hernigau, who published a variation of this core decompression by adding autologous graft in his decompression tract. And he also devised and elaborated on all the process of concentrating and reintroducing the decompressed femoral head. He also detailed on all the harvest techniques and the number of colony forming units he was injecting into this tract. And he considered patients in the pre-collapse stage of the disease and shown that there is a lower rate of total hip arthroplasty needed in all those patients who underwent his modification of core decompression. And all the functional outcomes were significantly better compared to the earlier core decompression method alone. And BMAC technique was propagated from here on as a standard of care in the management of early disease of osteonecrosis in femur head. And then came the Ganji paper. Initially, it was of less numbers. Only 24 hips were considered. However, it is taken across 5 years, and he found that only early advantages is seen in the cases who were treated with BMAC. And at the end of 5 years, they're all the same. That was his conclusion. And later, our Indian RK professor conducted RCT and found that there is significant functional improvement. And interestingly, he noted that all the cases who had trauma as the etiology of femur necrosis had a better outcome compared to other non-traumatic causes. And the paper by Tatabi shows that there is no correlation between the outcome and the number of cells which you are injecting. This noted from this study. However, all these studies are of short duration and less number of cases being involved. So we just look into the large studies with longer follow-up. This study by J.S. Kang shows that there is no difference in the stage progression between the groups. But however, across 3 years, the number of patients requiring total hip is significantly reduced in patients undergoing BMAC with core decompression. And Hernigau further expanded his treatment group and followed it across a long period of 25 years and shown that all the patients who were of osteonecrosis due to corticosteroid use were taken into his study, and they are all in the pre-collapse state. And the side which is more affected is being given with BMAC therapy. The other side is given with core decompression alone. And he found that there is 3 times more likely chances for the patient to undergo total hip if they are treated with core decompression alone. And there is significant improvement in all functional outcome parameters, which is favoring BMAC therapy compared to that of core decompression. And from this paper on, there are multiple RCTs and studies which are being propagated and performed, showing that core decompression with BMAC is superior to that of the standard core decompression alone for the young patients presenting with osteonecrosis of femur head. And if you can see that, there are plenty meta-analysis also being published. You can see there are 6 meta-analysis published on the same topic in a span of 5 years. And hence what we did is, we did a systematic overview of all these meta-analysis and summarized their results and gave our recommendation for the treatment option. And we included all the reviews with the meta-analysis and at least considering one of these outcome parameters. This is the net outcome results of all these meta-analysis. Everything is in favor of core decompression with BMAC therapy. If you can see that the pain is significantly improved and all the functional parameters are improved and the femoral head collapse is being contained and the necrotic area is significantly reduced and the requirement for secondary procedures such as vascularized bone graft or total hip is significantly reduced in patients undergoing bone marrow aspiration concentrate inside that of the core decompression tract. And there are limitations. If you have we look into the net success rate of using this therapy also, we come across 65%. We didn't go beyond that. So what are the things which is confounding our results? We just analyze that, and you can see that the studies included in this meta-analysis had heterogeneity regard to that of the graft material that is being used and the number and the diameter of tracts that is being created And also the grading systems that is being used, it is different, and the etiology of the hip necrosis is also different. And one finding from our study is that in all the cases where necrosis is due to systemic diseases, there is not much of functional gain with the BMAC therapy, because the milieu per se is not conducive of regeneration. Whereas in case of preventable deformities or short obliteratable deformities or conditions such as high dose steroid therapy or trauma, the outcomes are significantly better. So to summarize, we give a level 2 recommendation that bone marrow aspiration concentrated therapy is far superior compared to that of core decompression alone, and it gives a better pain relief with significant functional improvement and delays the collapse of the femoral head, thereby reduction in the number of patients requiring total hip arthroplasty. But the key to success with the BMAC therapy is patient selection, because if you select a patient early in the pre-collapse state, and if the etiology is one that could be eliminated, such as a trauma or a high-dose corticosteroid treatment, you will definitely have a significant good outcome compared to that of other systemic diseases such as vasculitis or sickle cell and so on. You can see the clinical examples of our own results. You can see this is a pre-op X-ray showing the sclerotic necrotic areas in the femoral head. This is 1 year after the core decompression with bone marrow therapy, and this is after 2 years. You can see the resolution of all the sclerotic areas and good architecture of the bone being reformed. Thank you.
Thank you, Dr. Satish. I have a quick question. It's a technical question. Once you do the core decompression, where do you place this BMAC? That's the first question. Can you answer that?
Yeah, once after the core decompression is being done, we just usually seal the track with the bone wax and then inject the BMAC within the track so that it gets absorbed to the site of osteonecrosis.
So what you mean is you're going to close the track outside with the bone wax, isn't it? But then what about the already established hip arthritis, if it is there? Do we inject into the joint also at the same time, into the hip joint?
We usually give it only in the necrotic sites and we don't inject it to the joint.
So you don't inject into the hip joint. Then if it is already established grade 2 or grade 1 osteoarthritis, then how do you go about it?
Just wait till the necrotic patch is getting reconstituted due to the therapy.
All right.
Primarily with the injection to the joint person.
So, right. You don't inject into the joint, you go inject into the track so that it reaches to the necrotic area only. Right. Okay. Do you have experience with any intraarticular injection apart from the BMAC when the associated osteoarthritis of the hip is present?
We don't inject it to the hip joints. I have experience of injecting to the hip joint.
Right. Thank you. Thank you so much. Any other comments from our colleagues?
For you, any choice of the graft, the bone graft, what you use, any preference, how you prepare it?
We use iliac crest graft only, sir.
Yeah, you asked, I think
fresh iliac crest graft.
Yeah, fresh iliac crest graft, sir.
And how do you make? How will you actually make sure that that goes right up to the head of the femur? Obviously, from the trochanter, you are decompressing.
Through the track, we just place the BMAC concentrate so that it gets filled to the track and it gets reabsorbed to the necrotic area.
No, but how do you make sure that the bone graft actually reaches to the place wherever you want?
You mean the cannula or what you use? Do you use your Jamshedi needle to go up to the track, to reach up to that and withdraw the needle, or you just keep the needle at the entrance and push it forwards? Because I think one of the challenges is to prevent the back seeping of what we inject.
Exactly.
You tilt the table to the other side as much as possible. And in fact, in 1 or 2 places, we have put one of those bioceramic screw, which we use for the ACL, just to keep it at the end of just a couple of turns at the end of the track, and then put the same Jamshedi needle, you push it inside, and then you tilt the table, for some time, and then you unwind, and then you use the bone wax, because again, it's all learning experience. Sometimes when you put the bone wax through the needle, through the bone wax to reach up to the subchondral area, and as you withdraw, once the BMAC was not going in, and then when I withdrew the needle, I saw the wax is actually blocking the end. Now, after going through the bone wax, I try to put the other stillet, make sure the end is free, and then you learn as you take. But it's quite a challenge to really prevent the backfilling. I think that's the question as to whether you use the arthroscopic cannula. I've tried the arthroscopic cannula. I've tried the Jamshedi needle, the one which you try to aspirate. Two of the companies, one is a slightly wider bore, because remember your channel is about 7 mm or 6.5 mm, but the cannula you might use is much smaller diameter.
Narrower.
So the backflow might be there. I think Dr. Reddy, I think that's what he wants to know as to what you use to reach up to the subchondral area. I think each one of us may be using different one, and be quite useful to know. Because I saw in your post-year X-ray, right at the entrance, there is a sclerosed area. In fact, I was wanting to ask you, because I've been told by the company chaps who come that some people put a collagen or it's like a soft gel along with the, just in front of the bone wax, they put soft gel, sir. They pack it with soft gel. But I really don't want to pack anything into the canal.
Okay.
What do you use, Dr. Reddy? You pack it with what do you use?
Yeah, nowadays the company people are actually giving us sort of conical type of graft.
Okay.
So we are using the screw, what you are saying, ACL screw.
So keep it at the entrance, okay?
Yeah, and also sometimes without that also, I remove the foot from the fracture table. The technician will actually take away the foot from the fracture table.
Okay.
And so that leg will become free.
All right.
And then he will internally rotate and flex it.
Okay.
So we don't need to do anything to the table. The technician will actually, just before injecting, technician will take the foot out of the stirrup and turn internally and flex it. So the head is in the dependent position. So even without blocking the orifice, if you inject, that is going to stay there for 10 minutes. Once it sets in, whichever way you want to block, you can block it.
And recently we had to do a bilateral, and I tend not to do even joints. I try to do it at least 2 days later. I don't want the person to lie on a operated wound immediately. If situation permits, I put it for 2 days later. But recently we had to do a bilateral AVN because, as you know, most of the time there is some changes on the other side also, and the patient would want to go on the other side as well. So then the registrar asked me afterwards, sir, when you are turning to that side, now what's going to happen? You're tilting the table to the other side. I said I blocked it at the end with the bone wax. But I guess.
But in about 5 minutes, 6 minutes, it sets anyway. But all my cases, by definition, they are bilateral. Because patient may come for a right hip pain, but invariably the right hip may be in advanced stage, which I can't salvage most of the time. But the other hip, which he has no complaint, maybe if you can stage 1 or 2, that's the one I feel that I can save it. So I recommend strongly for the other side, maybe not the one which he came for. Anyway, so all my patients are bilateral. So on the fracture table, whichever side I am injecting, the technician will take the foot out, will turn the leg in and flex. So once it sets, put the graft, close the wound, straight away go to the other side. Again, the same foot out of the stirrup will be repeated. And once it sets after 5-10 minutes, then close the wound.
So does the weight-bearing status matter? Weight-bearing status matters because I kind of, because particular bilateral, you can't choose where to.
I allow them for the first 4 to 6 weeks with the walker to the washroom, from the bed gently to get out and not to go out anywhere, just to have baby steps to the washroom and back, preferably with an attendant and a walker.
So and, partial as required. Partial as
well, in a bilateral case, using a walker, I can't say it is partial. It is a full weight only, but as much as he can take with the walker. Some people clever enough, they can take most of the weight on the hands, But most of the people, I don't think they can really understand the difference
Exactly.
taking the weight through the hands or the legs. So in my opinion, I think they'll take full weight, which I'll allow them. But just a few steps gently with an assistance on somebody with the side to the washroom, gently and back. Apart from the washroom visit, rest of the time they are on the bed.
And does anyone have anything with the cultured bone marrow cells, like the region, like the chondron for the cartilage? Because it's a difficult situation.
For the last 4 or 5 years, Apollo is the one which got licensed to use Oscro.
Yes, Oscro, yes.
What you are
Yes.
saying about BMAC all the time, I am actually referring to Oscro.
Oscro, yes.
Yeah, we are using that on a regular basis.
So you wait for a month or two, depending upon when the patient can come back. It's a month, isn't it? It's a month, because sometimes patient ask you, in that 1 month, will it get worse? So ideally, you have to also ask them to rest or limit their activity for the month before this.
Yeah, month to 6 weeks. Yeah.
Before the Oscro comes back.
Yeah, because most of the patients can be outstation, so they may have their own logistics. So maybe month to 6 weeks, definitely no regular weight bearing for about 4 to 6 weeks.
But shifting from the BMAC before the Oscro came, do you find any difference?
No, I have not used BMAC on its own when it was started.
Okay, so you've been using only Oscro.
Yeah, when we started, it was Oscro.
Satish, your study is Oscro or a single stage, like you aspirate and give it straight away?
No, 2 stages.
Yours is also 2 stage, Satish?
2 stages.
Single, okay. Okay, thanks a lot.
Thank you, Dr. Satish, for a good talk. Now we move on to the third talk, that is the role of minced articular cartilage in the treatment of articular cartilage defects by Dr. Tilak.
So I'm going to talk about using the graft net for osteochondral defect of the knee. Unfortunately, because of the lockdown and patients who came after that for surgery turning positive, I just have one case, but it's a 1-year follow-up. So this actually came about when this was new and there's hardly any literature. And the objective of all these cartilage procedures, we know, is to get finally a hyaline-like cartilage. So the graft net is a single-stage procedure, and that's by Arthrex, by which you can do an osteoarticular autograft transfer, and it's arthroscopic. So this is a collector, and it's a very simple surgery by which you get cartilage from the non-weight-bearing surface and transfer it to the defect after mixing it with PRP. So this is a 17-year-old male who had needle-sided knee pain for 6 months, and he had, you can see here, there's this defect here, and he had osteochondritis dissecans, so no history of trauma. And at arthroscopy, this is the lesion which we see on the middle femoral condyle. And this is after microfracture and drying the defect. So we got about 2 to 3 cc of cartilage through the suction which is connected to this particulate collector, and we mix it with PRP, and this is showing the injection into the defect. And here you can see it being applied to the surface of the defect. And once this is done, we apply fibrin glue so that it sticks on to the surface. And after waiting for about 4 minutes, that's all you have to do. The surgery is over. So the post-operative regime is toe touch for 6 weeks and progressive weight bearing. Now, this surgery was done in December of last year. And 6 months later, when you did the MRI, you can see the defect healing. There's still a little bit of edema though. And this is about 2 weeks back, which was about 11 months since the surgery. And you can see good healing. And the edema has come down completely, and the cartilage is, you can say it's healed. And if you look at comparative X-rays, MRI films, you can see the pre-op defect 6 months later and at 1 year. So this is a very simple procedure to do, and that's where its attractiveness is. And it appears promising, though most studies are required, and you need larger defects to say whether this is successful or not. Thank you very much.
Thank you, Dr. Tilak, for a crisp and a brief presentation on the GraphNet. Now, I welcome any questions from our colleagues in the audience.
So this is like Condron, isn't it? Like same thing.
More or less.
But it's a single stage, is it?
Yeah.
So this is a single stage.
Dr. Tilak, are you on the line? Hello.
I think net connectivity.
Net connectivity
really,
is a problem.
Really temperamental for me also. Yes.
Yeah.
Do you use Condron, Krish?
No, I don't use Condron.
Because I can. It's a two-stage. So I think
Yeah,
sometimes because people come to you, it's sometimes if they are from far away.
Yes, that's right.
To make them come 2 times, it's a challenge.
It's a challenge, number one. Number two is, as you rightly know, in our patients, the monetary aspects will be there. Then people think that we are doing surgeries twice rather than
and 100% result. So the other things, so because all these things are, yes, it's evolving, and in select cases we get good outcome.
Yeah, that's right.
But at the same time, you got to be a bit guarded as to what you can promise them, and you can say, instead of knee replacement or prevention to progression to knee replacement, this is an option. But sometimes, like you say, if you say 2 surgeries, and after 2 surgeries also, if the graft doesn't incorporate well or settle very well, then it may not be successful. It's a challenge. Okay.
So my main aim was to do a pilot study initially on a good patient. So that's why the 17-year-old male I thought was a good patient. Before
absolutely, yes.
On to older and as an adjuvant to even high-tubule osteotomy. So unfortunately, because of the COVID, a lot of problems in getting patients this year. So we aim to do a study, and it's been written up for our IRB so that we can proceed. Like you said, arthroscopically.
So in a mechanically aligned knee, this alone, probably in a knee with a varus or some alignment issues, you probably later on combine it with osteotomy as well.
Yeah, that's right.
Yes, correct.
Thank you, Dr. Tilak. Thank you, Dr. Tilak. Any more questions on this particular talk? If there are no more questions, thank you very much, Dr. Tilak, for your beautiful demonstration on the case also. Now we move on to the last talk of this session. That is by Stephen Peloquin from Kansas University. He's going to discuss the various clinical case discussions, his regenerative medical approaches in spinal cord injury. He has an extensive approach in this particular field. Now, I request the organizers to.
My name is Dr. Steve Peloquin. I'm double boarded in anesthesiology and pain medicine. I practice in one of the middle states in the United States. I had practiced anesthesiology for about 10 or 12 years and pain medicine for about 16 to 18 years, and have been doing stem cells for 6.5 years. I have done over 800 spine stem cell patients. And many of these patients, in fact, the vast majority have multiple targets. So I have probably deployed stem cells in around 7,000 or 8,000 different sites in the human body, including joints, around nerves, tissues, in the epidural space, and in the intrathecal space. This slide is a little antiquated. It's from one of my original presentations, The Promise of Stem Cell Therapy. Stem cells do turn into all the tissues in your body in the laboratory when they're induced to do so. But for our purposes and what I practice, stem cells don't turn into other tissues. They're there to assist existing stem cells in those tissues in their reparative processes. When the stem cells built your body, they deposited stem cells in little niches in all the tissues, with the exception of probably ligaments. Those stem cells are there to do minor repairs and regeneration. When there's a major injury, those stem cells are overwhelmed and they send out chemical signaling for help. There are places in your body where stem cells are in depositories, such as the bone marrow. But the depository that I use is in your torso, in between the fat cells around the capillaries. Thus, they're called adipose-derived stem cells, but they do not come from the fat. Those stem cells are 200 times smaller than red blood cells, but they are packed full of packets called exosomes that are full of growth factors, messenger RNA, microRNA, all the things needed to help the existing stem cells in different tissue niches to carry out the reparative processes. Stem cells can do many things. The first thing that they do is migrate to targets. In other words, if I can't deploy them in an exact target, I can count on them being able to migrate almost anywhere throughout the body. Once they are there, they have great anti-inflammatory effects early on. In brain damage, they can cause apoptosis or stop the death of brain cells. They also have regenerative properties. That takes months, usually, although I've had a patient respond completely in 8 weeks. They decrease scar formation, and they also are great at immune modulation. We will be discussing case studies that utilize these qualities of stem cells. Again, I've been asked to present case studies, but I don't know your background, so I thought a little bit of basic information on how stem cells work would be appropriate. Hello, the first case study is a 24-year-old male veteran of the Army. He was in a motor vehicle accident in 2013 with traumatic brain injury, had diffuse axonal brain injury, suffered severe migraine headaches because of that, had severe hypertension. The medications of note in this list are he's on baclofen oral and also intrathecal baclofen to control contractures and spasming, and on Effexor and venlafaxine for severe depression. His past medical history is significant for right shoulder bursitis, drug-induced constipation, hypertension, major depression, tendinitis, multiple fractures that were repaired. Other surgeries include intrathecal pump, in which we're pumping baclofen in with a variable rate during the day. His disabilities or impairments include decreased alertness, unable to stand or walk since his traumatic brain injuries, wheelchair bound, had difficulty even holding his head up. It was always tilted severely to one side. He couldn't assist with transfers. He couldn't talk. Had very poor memory, couldn't use his hands. He could move his arms some. He doesn't sleep through the night at all. He complains of constant pain. He can't sit up on his own. He can laugh and smile, but cannot speak. We deployed stem cells several years after his injury. I placed 11 cc's of stem cells into his intrathecal fluid. We also placed about 19 cc's into his IV. Within days, his mother noted, even she claimed on the ride home, which was several hundred miles from our clinic, he was lifting his head up better and looking around, which she hadn't seen before. So we treated him 3 different times. He continued to have increased alertness. Eventually, after the 3rd treatment, he started to become more of an angry young man, I think because he was more aware of his situation. He was able to make more verbal sounds, but could not formulate words. He was able to assist his parents with transfers. He actually could stand and squat after our 3rd round of stem cell deployments. We did them approximately 6 to 9 months apart. His right side, which has always been his worst side, was starting to wake up. His mother very proudly sent us a video of him for the first time writing his name. He can feed himself, although it was quite comical the first times he was trying to scoop up peas in a spoon and trying to get it to his mouth. But his mother was crying in the background. He had longer attention spans. Short-term memory was improving. Again, he can stand and squat with minimal assistance. And his oral meds really didn't change. He still was on the oral baclofen and the intrathecal baclofen. Case study number 2 is a 77-year-old female. And by the way, all these case studies I present today are at least 5 years out from their deployments. Her diagnosis and complaints, CT scans showed anterior listhesis of C4 and 5, retrolisthesis of C5 and 6 with moderate spondylosis, joint arthropy, and spinal stenosis. She had neck and arm pain, bilateral shoulder and thumb pain, back and leg pain. Oral pain meds before stem cell treatment include Actique, which is a buccal, fentanyl lozenge, which you just slip underneath your tongue, Cymbalta dilaudid, Exalgo extended release narcotic, oxycodone for breakthrough pain med, Percocet for breakthrough pain med, and Subsys sublingual spray, a spray of fentanyl and give you results. It says in 2 minutes. Most of my patients get relief in a matter of 20 seconds. She has an intrathecal medication pump with what's called a PTM, personal therapy manager, where she has a severe bout of pain. She can give herself an extra bolus through her intrathecal pump, which will take 20 minutes to start to work. So when she has severe pain, she'll spray the sublingual fentanyl, or if she doesn't have that, she'll use the buccal lozenge, which takes a little bit longer to work, and they will last about 20 minutes, about the time her intrathecal pump meds will start to kick in. Past medical history is significant for severe anxiety, major depression, narcotic dependence, CRPS of the GI tract and abdominal wall, bursitis of shoulders and hips, fibromyalgia, osteoarthritis of the spine, and multiple major joints with arthritis. Surgeries are significant for a spinal cord stimulator, which I placed in her with some benefit, intrathecal pain pump, which has given her life back and kept her out of nursing homes, and bilateral total knee arthroplasties. Disabilities and impairments include moderate to severe hearing loss. She uses a cane to walk. She has very strong prescription glasses. She can only walk 1 or 2 minutes due to severe pain. She can't climb any stairs, can't drive, and can't sleep very well. Stem cells are deployed in her cervical epidural space, cervical facets, lumbar epidural space, bilateral shoulders, bilateral thumb joints. The results: about 3 to 6 months after stem cells, she threw her hearing aids in a drawer, claiming they were too loud. She couldn't turn them down low enough. We had the luxury of she'd had a recent audiology exam prior to stem cells, and we sent her back for a repeat exam without telling the audiologist, and the same for her ophthalmologist. She had a 30% decrease in strength verified by our ophthalmologist. Again, we had pre-stem cell and then a post-stem cell exam, and neither the audiologist or ophthalmologist were aware that she had stem cells, and they were totally astonished at the improvement. She only uses a cane for security from falls, doesn't need it. She exercises on a treadmill for 15 minutes at a time. She has less difficulty with stairs. Her neck range of motion improved 80%, neck pain relief 75%, low back pain relief 80%, leg pain relief 90%, thumb pain relief 70%. Her anxiety and depression is much improved. She no longer talks about the GI tract and abdominal wall pain from the CRPS. And her oral pain meds have decreased 40%, including the intrathecal Dilaudid that we administer. She no longer uses the Subsys spray or the Actique lozenges. Case study number 3 is a 67-year-old male with diagnosis and complaints of degenerative disc and degenerative joint disease of the cervical, thoracic, and lumbar spine. He has spinal stenosis in the lumbar spine with radicular pain. He has neck pain, thoracic pain, low back pain. He has bilateral sciatica because of the spinal stenosis. Oral meds prior to stem cells include Lyrica, oxycodone. Past medical history significant for hip bursitis, chronic depression, erectile dysfunction, femoral neuritis, ilioinguinal neuralgia, compression fractures, rib pain, opioid dependence. Surgeries include epidural steroid injections, really not surgeries, but procedures on a regular basis, appendectomy, right shoulder rotator cuff repair, left shoulder replacement. Disabilities and impairments include cannot walk very far without severe pain. He's antisocial because of the pain. Can't work on his farm because of the pain and dysfunction. He has erectile dysfunction, opioid dependence, and difficulty sleeping. Stem cells were deployed in the thoracic epidural space, thoracic facet joints, lumbar epidural space, lumbar facet joints, and of course, we always place stem cells into the intravenous space with every patient. Results include quality of life increased 100%, activity increased over 500%. 3 months after stem cells, he was able to re-roof his barn with 2 day laborers helping him, and was able to sandblast and repaint his farmhouse, which he hadn't been able to do for about 15 years. He also, in addition to his farming, he also likes to work as a DJ, which is an American term for someone who goes and plays music, sometimes recordings, various venues. He goes to nursing homes and plays the music that the people who are 60, 70, 80 years old like to play. And he sings and plays musical instruments with the previous recordings. He's quite good at it. And that's how he gives back to his communities. And he was able to do that again. He can walk 5 to 10 times as far before he has pain. He has great resolution of his erectile dysfunction. Oral meds were decreased 90% after stem cells. This is a picture of the state that I was born in, New Mexico, which has one of the largest cave systems in the world called Carlsbad Caverns. And this is part of the Lechuguilla branch. And those are huge crystals, as you can see, compared to the man. I presented case study number 4 if we have time. This really isn't a spinal cord injury, but it's a remarkable case showing the effects stem cells have on a aberrant immune system. This gentleman was a 25-year-old male. He has primary sclerosing cholangitis, treated at Mayo Clinic, one of the leading medical clinics in the United States. They would use little angioplasty balloons to open up the bile ducts and pancreatic ducts that the cholangitis would scar up. He has a partial ACL tear in his left knee and some general arthritis in his wrist. You have to understand in the United States, a male will start working on the farm and ranch at age 4 or 5. Oral pain meds prior to stem cell therapy, none. Past medical history, severe abdominal pain, arthralgia in both hands, chronic fatigue, hepatitis, indigestion, and diarrhea. He was 6'2" and about 150 pounds because he didn't like to eat. It was painful. Past surgeries, he had ERCPs 2012, 2015, a laparoscopic cholecystectomy in 2009. Disabilities, chronic fatigue, nausea, vomiting, diarrhea, abdominal pain, indigestion, left knee pain. He refused to ask his high school sweetheart for her hand in marriage, despite her requests, as he didn't feel that he could take care of a family. He just inherited his uncle's ranch, which he said he was going to have to pass off to a cousin because he was too weak to farm and ranch. I contacted Mayo Clinic, who was treating his cholangitis for 8 years, advising him that eventually they wouldn't be able to open up the scarred ducts and he would have to have a liver transplant. Well, that day had arrived, and he did not, at his young age, want to live with a liver transplant and all the drugs involved in maintaining that, and the weakness and fatigue. We placed stem cells, 5 cc's, into his intraperitoneal cavity as close as I could get to the liver, but it was severely scarred up for the 10 years of the inflammatory process, and into his left knee and also into his IV. Results. Just a few months afterwards, he was 70% better. He had 30% more energy. His appetite was much improved. He gained 10 pounds in the first month and a half after stem cells. He was no longer feeling sickly and didn't get all the viral and bacterial infections, as his immune system wasn't focusing on the liver, pancreas, and he actually was able to eat. He had decreased nausea. His sharp arthritic hand pain flares subsided completely. The left knee pain was gone, 90 to 100%. He went back to Mayo Clinic in 4 months for his yearly checkup, and they did an MRI of his liver. Pancreas said it hadn't looked that good in 5 or 6 years, and they took him off the liver transplant list. He was able to work to restore the farm and ranch that he inherited, now that he has increased energy and stamina, and he asked for his high school sweetheart's hand in marriage. Mayo Clinic was very impressed. He did very well for 5.5 years. And then I recently had a call from Mayo Clinic asking me to redo the stem cells as his liver enzymes are just starting to increase. And we just did that a couple of months ago. He's happily married, has 2 children, is farming and ranching on the ranch he inherited from his uncle. Again, totally changed this young man's life. Again, this is the Lechuguilla Cave with the large crystals. You can see how small the men are compared to this. This is in the southern part of the state of New Mexico. I don't know how many more. This is case study number 5, if we have time. He's a 52-year-old male construction worker / minister who has 7 adopted children, besides his own natural children. Diagnosed with degenerative disc and joint disease of the cervical and lumbar spine with various degrees of spinal and foraminal stenosis. He's post-laminectomy of the lumbar spine, oral pain meds, pre-stem cell therapy, hydromorphone, oxycodone, cyclobenzaprine, Cymbalta, Exalgo, Lyrica, and high blood pressure medication. He also at times was on antidepressant and anti-anxiety meds. Past medical history, chronic overexertion, abnormal gait, shoulder bursitis, drug-induced constipation, type 2 diabetes, history of hepatitis, hypertension, irregular heartbeats, depression, fibromyalgia, lumbar spinal stenosis, osteoarthritis of the neck, shoulders, low back, with sciatica, sacroiliitis, and cervical radiculopathy. Surgeries have been performed on his neck, shoulder, lumbar sacral region, and I had placed a spinal cord stimulator implant, which had given him 70% relief of his back and sciatica pain. Disabilities and impairments. He has pain with any strenuous work, ranging to a 9 to 10 out of 10. Cannot lift over 30 pounds without severe pain, can't interact with his children after work. He's so exhausted, so much back pain, just want to go into his bedroom, turn the lights out, and lay on a bag of ice. Can't attend and watch his children's sports activities and other activities, cannot coach his children's sports teams, cannot preach, stand at the podium at church, cannot ride his motorcycle, which he and his wife use as their hobby. He's loss of neck and back range of motion, 70% reduction in working and physical abilities, and has antisocial behavior in the sense that he doesn't want to be around people. When he's done working, he just wants to go and be by himself. We deployed stem cells in his cervical facet, cervical epidural space, lumbar facets, lumbar epidural space, and into his intravenous space. Results: hip and leg pain is only annoying now. His spinal cord stimuli actually works better now. Actually, we were eventually able to shut it off. He was a smart man. We didn't remove it though. Shoulder pain reduced 70%, neck pain reduced 90%, low back pain reduced 75%. He's attending all his children's activities. They have faith in him as a father again. He's able to ride his motorcycle with his wife. He's been able to return to preaching at the church. He is discontinued all of his narcotic pain meds, his anti-inflammatories, his muscle relaxers, his antidepressant meds, his anti-anxiety meds, and yes, even his hypertensive meds, as the pain was driving his blood pressure. These are some of the ruins of the native people in the Americas that lived underneath overhangs in the cliff in the southwestern United States, the area where I was born. And this is where I live now in Kansas, in the heartland of the United States. And yes, this is a large tornado, extremely destructive. Thank you very much for listening. Hopefully
Thank you, Dr. Steve Poloquin, for your nice case studies. I welcome any questions from the audience.
Yes, indeed, it was really nice case studies. Can I ask you, in some places you put 5 ml, you put 11 ml, you said that's depending on the joint or the space available, or the severity of the disease, and in one case you also put intravenous. Now, is that how you decide that?
Dr. Steve,
you need to unmute yourself.
You're muted.
You can unmute.
Okay, I see it. Now can you hear me?
Yes, please.
Yeah.
Is anybody seen a charger, Apple charger here?
Okay.
Apple
Can you hear me
charger.
now?
Yes, very clear.
Okay, let me answer that question.
It's left with some
My predecessors, especially Dr. Jackie
Apple
C,
charger, right?
who has been doing stem cells
for
20 years. And
iPods,
he
Apple charger.
experimented with how much to place into different joints, and he passed that information on to me. I've expanded on it. In the spine, the facet joints can handle about 1 cc. So I'll inject 1 cc into a facet joint, pull the needle out, and inject a half to 1 cc. In the knee joints, usually 4 or 5 cc's of stem cells are adequate, but if the knee is in critical condition, I might put 8, maybe even 10. In the spinal fluid, I usually will put about 8, maybe 10 cc's. If I put more than that, it's a little disconcerting to the patient, the osmolality differences between the stem cells and the spinal fluid and the temperature changes. You have to do it very slowly.
And the source of the stem cells?
Mesenchymal stem cells in the torso of the body, in between the fat cells.
Okay.
They're called adipose derived, but they are not from the fat tissue. They just happen to be positioned in the body along the capillaries in between the fat cells.
Okay. case number 3, there was improvement in knee pain because you have injected the knee and then you also injected the facets. So the hand pain has improved because probably primarily the hand pain was from the neck related issue, or the hand pain was a local issue.
It could be both. And we used to inject a lot of the joints in the hand.
Okay.
And it became quite painful for a lot of patients, and that's where we rely on the intravenous stem cells, and they will migrate to the targets in the hand. And if someone has a lot of hand pain, we'll make sure we have a large amount to place into the intravenous space.
Thank you.
Thank you, Dr. Steve. Any more questions to Dr. Steve Peloquin? If there are no more questions, I sincerely thank Dr. Steve for your excellent presentation. Thanks for accepting our invitation. And now we move on to the panel discussion. The moderator will be Dr. Satish Kumar Kamshetty, and the panelists are Dr. Madan Jayaraman, and Dr. Satish Muthu, and Dr. Ramiredi, and me, all 4 of us. So may we have the slides for the panel? Next slide.
Yeah. Next slide, please. Yeah. Thank you. Dear teachers and colleagues, a very good evening. I sincerely thank you, Dr. Subramaniam sir, for giving me this opportunity. Am I audible? Dear panelists, Dr. Madan.
Yes.
Yes, sir.
Yes, Dr. Satish.
Yeah, Dr. Ramiredi. So this orthobiologics is still a baby in the lap of orthopedics. Slowly, by year, it is increasing. The importance is increasing. I think you all agree. Without any further discussion, we'll move on to our first case. This is a 46-year-old female who has severe right knee pain. On examination, she has a medial joint line tenderness with a visual analog score of 9 out of 10. She doesn't have any comorbidities, and there is no history of any injury. There is no constitutional history. At this stage, I would like all my panelists, one after the other, what are your orthobiologic options for osteoarthritis knee? If it is a primary osteoarthritis or if it is a secondary osteoarthritis, I want you to tell your way of treating this problem in orthobiologic way, please. Dr. Ramiredi.
Yeah. First of choice will be the PRP will be do good in this type of cases. But before that, we need a assessment to know that any varus deformity. So before giving it, scanogram has to be taken. Once we rule out any misalignment and it is okay, then PRP is the best choice in this type of medial side narrowing cases.
Okay, Dr. Satish Muthu.
Yeah, is there any specific way to say only PRP is good then the BMAC? Because initially we were using PRP and now we have started using BMAC. Do you find any particular reason to use only PRP, sir?
No, actually PRP is very affordable. That's why we are using PRP. BMAC is bit expensive compared to PRP.
Oh. Only because of cost effectiveness, your
yeah.
Okay.
Yeah.
The result when it is compared with BMAC, did you do any studies like that comparing
we are in the process of enrolling patients. We have around 10 in each site and it is still ongoing.
Dr. Madan, what is your comment on this BMAC versus PRP?
Yes, I have done studies both in PRP as well as BMAC, even autologous conditioned serum for ONE. I have used only for grade 1 and 1, 2, and 3. 3 only for BMAC, but this is being grade 2. I would go for BMAC rather than PRP. PRP is just, it will give a short lasting effect. It is not a long lasting effect. And moreover, PRP is not really it is not a regenerative modality.
Tool.
It is not a regenerative modality. So To regenerate the cartilage, I would first go for MR cartogram, whether the cartilage thickness I will see. Then I will decide upon whether the thickness is less. Okay, fine. Anyway, the medial joint line is not at all seen here. It is almost touching each other. So I will go for BMAC and I will wait for the process of regeneration. And I would take the post 12 months or 18 months or 2 years follow-up. I'll take one more scan cartogram to see the thickness. So the best option, what I prefer for this particular case is BMAC.
Okay, so I think this whole thing will good for primary osteoarthritis. If it is a secondary osteoarthritis, what precautions you will take, Dr. Ram Reddy? Dr. Ram Reddy.
Yeah. If in case of secondary osteoarthritis, mostly what is the primary cause we have to rule out. So most of the times it is due to varus deformity or maybe due to initial articular damage, maybe the changes will be there. So based on that, we have to go on BMAC on secondary cases or correcting the deformity before going to the any orthobiologics.
Yeah, I have a question for Dr. Satish Muthu. Suppose the same female, after taking a tunnel view, osteochondritis dissecans is seen. How you going? How you will be approaching that patient?
Even if the patient has osteochondritis dissecans, if it is strictly limiting her movements, and you can go for an arthroscopy, remove all the osteophytes, and then after the procedure, you can have a regenerative tool like a BMAC or something.
Yeah, after giving a BMAC or PRP, the patient will have a good relief of pain, or there will not be any relief of the pain. In that case, retrospectively, what will be the cause for that success or failure? Whether the technique or the molecule what we are injecting into the knee, or the case selection?
The case selection matters. If you are taking a case which has which doesn't has even a layer of minimal layer of cartilage, you cannot regrow a cartilage, or there is no space for regenerative tool to work over there. So if you select cases in stage 2 or stage 3, there is much of space to work on. For a grade 4, the results will definitely be less.
Okay, suppose you have counseled for both BMAC, and the patient is asking you for both BMAC and PRP. What you will suggest for knee joint pain?
Knee joint pain, depending on, I will go for BMAC definitely, because PRP is going to give only the inductive factors, but BMAC will give the MSCs, which will work on the cartilage regeneration. So I will prefer BMAC. That will be my choice, and I'll leave it to the patient to decide.
Yeah, I have a question for this Madan Jayaraman sir.
Yes, sir.
What is your longest follow-up of this PRP?
So PRP I have followed up for 2 years in my postgraduate time. My thesis on post-graduation is PRP in musculoskeletal disorders, where I included all the diseases, and after finishing my cases for that thesis, I extended the study. So I did till 2 years.
Okay. In these 2 years of practice, is there any changes happening in the PRP extraction or PRP application or any other things?
Sir, extraction wise, I improved my centrifugation, all these things, technique, how to prepare and extract PRP. I improved a lot from day 1 to second year. So that differed a lot. And moreover, when the patient came out with functional outcome, there was a definite change. After 1 year, patients came up with recurrence. There is pain. Again, the pain have started. So second dose and third dose, I instilled in that knee joint. So PRP as such has only a short-term pain relief, and better is always BMAC, mesenchymal stem cells.
Because what with the lectures by Dr. Ram Reddy and Subramaniam sir, we will come to know that leukocyte depleted PRP are the best PRPs.
Yes, sir. For knee joint, only leukocyte depleted will be given.
Yeah, and hard spin, double spin PRP yield
Yes,
is
sir.
very good.
Yes, sir.
2 years before, I don't think so. This topic was there.
No, sir. I have done only differential centrifugation. Even I have published various papers with differential centrifugation. I have my own protocol and for preparation, all these things. So I have done in 2016, 17, 18, 19, all 4 years I have done only differential centrifugation.
Can I ask you one question now? In this particular case, you see that there is almost a bone on the medial compartment. There is some axis deviation. Without correcting that, be it a PRP or stem cells, whatever it is, they're not going to have a chance to regenerate unless you really shift that weight bearing away from for the cartilage to recover, helped by PRP / BMAC, whatever. As long as there is a continuous insult on that loading on that medial compartment, the chance of it recover is less likely. So this particular case, far better if you do a HTO and then give a chance. Preferably you do an arthroscopy before to see how much cartilage is attenuated, damaged, and you change the tax from medial loading to the natural 62.5 axis deviation without doing axis deviation by merely stuffing the joint with PRP or BMAC. I don't think it's going to be of much use. It's a mere placebo treatment. I'd like to. If you really want that to help, you have to change the axis deviation. What about the? What's your comment on that?
Yeah, for this case, sir, actually, we have counseled for HTO. Patient did not want any HTO or any invasive procedure to be done. So to show the benefit, we have given a little bit support and we have injected BMAC. Can we have the next slide? Yeah, so we have given 5 ml of BMAC along with injections in Invisc 1. And to know the effect, we have given only paracetamol tablet. And we have given a little bit support. We have put her on NERVOM exercise and weight reduction and other lifestyle modification. Surprisingly, this patient has improved after 6 months. Next slide, please.
Yeah. Okay. I know, I mean, in this country, people really, it depends on weight-bearing X-ray or non-weight-bearing X-ray, it changes. But I agree that, you know, patient wouldn't prefer that. But however, in all rational sense, if you really want that to help, that axis has to be shifted, because already it is loading more and more on that. I published a paper on 18 cases, PRP and Synvisc. It does help. It does relieve the pain in through different means. That doesn't mean cartilage is going to really regenerate. We followed 2.5 years. But I'm really surprised to see that the medial joint space is opened up in here. Maybe if you look at that, you know, if you take a non-weight bearing X-ray, you might see like that compared to the previous one. So it's hard to imagine that the cartilage thickness will improve following BMAC.
Yeah, next slide, please. This is the cartogram, sir, pre-injection and post-injection. Next slide, please. Yeah, we'll move on to our next case. He is a 19-year-old male patient complaining of right hip pain. There is no history of trauma. NSAIDs did not decrease his pain. And all this workup is negative, including serum uric acid, TB workup, and rheumatoid profile. Next slide, please. Yeah, this is the radiograph of the patient with a uniform joint space narrowing in the right side. I would like to ask our panelists, how do you approach this patient in an orthobiologic way?
How old is this patient?
16 years.
It's not even fused his physis yet.
Yeah, 19-year-old. Sorry.
Get some
Dr.
vegetarian snack, huh?
Satish.
Vegetarian snack.
I
I asked
want you
for
to take this.
The joint space is significantly reduced. Is there any MR being taken for this case?
MRI has been taken. I'll show you the Please post the next slide. Yeah. So this is the MRI of the same patient. Okay, for this patient, next slide, please. Next slide, please, dear host. Next slide, please. Am I audible?
Yeah, you are audible.
Please go to the next slide. Hello. So we'll discuss here. So patient has approached a rheumatologist. The patient has been started with DMRDs like leflunomide, salazopyrin, and indomethacin. 6 months after the DMRDs, again X-ray has been taken, and that X-ray is posted. Unfortunately, yeah. Go. Yeah. Just yeah. So next slide, please. Yeah, this is the 6 months post DMRDs. There is some improvement in the joint space, but patient continued to have pain while squatting. Next slide, please. Yeah, right hip pain subsided, but gait pain improved, but he is having difficulty in squatting and difficulty in sitting cross-legged. So this patient is being counseled for BMAC therapy. Next slide, please. Yeah. So autologous mesenchymal BMAC therapy has been given under a fluoroscopy guidance with a joint distraction. That is intra picture. Post procedure salazopyrin is continued. Next slide, please. This is post injection, 1 year post injection. That still that joint space is uniformly improved, and patient has a severe reduction in the pain. In this context, we have taken MRI also. Next slide, please. Yeah. So joint space has improved, and femoral head is still viable. I want everybody, please comment at this. All panelists, Dr. Madan or Satish, please comment.
Yes, sir. I want to know how much, what is the dosage of BMAC has been given in this hip joint?
6 ml.
No, sir. What is the counts? Millions. How many millions?
Millions and all those things we did not do.
Sir, actually, there are a lot of studies stating that it should be more than 15 million cells. 15 million, 12 lakhs to 50. That's what, 12 to 15 lakhs.
Yeah.
More than 15 lakhs will give a better outcome. But Grenigo et al. In somewhere around 1995, I think it's almost 19th century, they have done a study and they have published like only 35,000 pure MSCs are enough to regenerate a whole femoral head. Only 35,000 they have mentioned. So I think there are a lot of controversies in this femoral head osteonecrosis, how many number of cells are needed. So it's all based upon how many number, expertise in preparing BMAC, all those things are needed for regenerating that femoral head osteonecrosis.
Dr. Madan, I agree with you.
Yes,
but
sir.
the whole issue is this case is not osteonecrosis.
Yes, I do agree.
This is a chondrolysis, if I'm right.
Yeah,
it's a chondrolysis, into which the MSCs were given into the joint. The number of cells to be given is 1 into 10 to the power of 6. That is what literature says per microliter.
Yes, sir. That is almost 10 lakhs.
That's what I'm talking about.
Yes, sir.
That is what 10 to the power of 6. So in this, when we given 6 ml of injection, that is the result which we got, which I wanted because usually in idiopathic chondrolysis, the policy is we'll wait and watch. So giving it to the power of, this kind of MSCs hasn't the result of formation of the articular cartilage. And you can see the
Yeah, follow-up X-rays, MRI is there. Please.
What is the normal chronology of the disease prognosis?
This is inflammatory arthritis, isn't it?
Yeah, that's right. That's right. So, no. Presentation, please. Presentation. We wanted to see the clinical pictures too. Result, clinical pictures and X-rays. Presentation, please.
Cartilage aspect for the earlier case, sir, between pre-op and post-op.
After this, we will finish. Yeah. Are you able to see the presentation?
No, sir.
We are not.
No.
There is some technical problem.
Yeah, I think I request the host to keep the presentation. Yeah, ask them to go back.
Yeah. This is where our discussion has stopped. Next slide, please. Yeah, this is how the patient is behaving 1 year following the injection. Yeah, next slide, please. Next slide, please. Yeah, this is 1 year following up the patient. Patient is able to do active straight leg raising and is able to sit cross-legged very comfortably. And X-ray is also taken 1 year after this. Please post the next slide. Yeah.
Is he still on DMRs?
Yeah, he's still on DMRD. Salazopyrin only. He's taking only salazopyrin. Yeah. I thank all the panelists for attending our session. Because lack of time, we are not able to discuss other cases. I hand over to Dr. Subramaniam sir for concluding the orthobiologic session of OASISCon 2020. Thank you.
Friends, really, it's a great experience. We have come to the end of the lectures and panel discussion. And it's a really great experience to learn from the foreign faculty, other faculty, and other panelists all about the orthobiologics. And this is beginning of the orthobiologics, perhaps in this. And I thank Dr. Madan Jayaraman, all other our friends, speakers, for the kind of enthusiasm they have shown to participate and to make this event a grand success. And my colleagues, Dr. Somashekar Reddy, Dr. Krishna sir, my friend Satish, and my other person, Dr. Sandeep Sridham, all of them worked very well for the success of this particular event. Once again, a special thanks to Dr. Charan and Dr. Steve Palaquin and Dr. Jagbert and Sanofi people, all of them who have really took out their time to participate in this session. And we have now seen different kinds of orthobiologics. Once upon a time, when we have started way back to 2010-11 time, that was really beginning. We were walking with a few steps. And now with the youngsters taking up, like Madan Jayaraman doing a PhD in this regenerative medicine, Satish Muthu's interest, and the seniors like Dr. Kosigan, Dr. Mohan Sir, and other people, all of them are now working together for the better understanding of the orthobiologics. And finally, I think in one of the lectures, a speaker told, Dr. Krishna sir in the beginning, what we are doing is from replacement to repair and regeneration. That's the, I think that will be the, we all see a day comes where this becomes a norm orthopedic tool. And really, this will be a boon within a decade time. Orthobiology becomes a boon to orthopedic surgeons in the treatment of musculoskeletal disorders in the coming decade time. I sincerely thank all of you once again. Now we move on to the free paper session. There are 5 free papers for the orthobiologic session. And I request the host to go to the session for the free papers. The first free paper is by Dr. Jaskaran Sandhu, a prospective study of intraarticular injection of platelet-rich plasma.
Myself, Dr. Jaskaran Singh Sandhu. I am presenting my paper on a prospective study of intra-articular injection of PRP in knee osteoarthritis. I will discuss my paper under the following headings. In the introduction, osteoarthritis is defined pathologically as being distinguished by the focal area of loss of articular cartilage within a synovial joint. This is accompanied by sclerosis of the underlying bone and varying degree of changes in the other joint tissue. The changes are synovitis, articular cartilage loss, subchondral sclerosis and cyst formation, and osteophyte formation. It is of 2 types, primary and secondary. The cause of primary osteoarthritis are genetic, degenerative, obesity, and aging. And the causes of secondary osteoarthritis are trauma, underlying joint disease, systemic, metabolic, and endocrine disorders, crystal deposit disease, neuropathic disorders, and miscellaneous causes. Symptoms are pain, stiffness, limited joint function. In signs, tenderness, joint enlargement, crepitus, limitation of motion, malalignment, muscle atrophy, and loose body. We can diagnose the case of osteoarthritis by the thorough history and clinical examination and confirmed by the radiographic examination. By the radiographic examination, we can grade the osteoarthritis into 4 grades according to the Kellgren-Lawrence classification that is based on the joint space narrowing and osteophyte formation. PRP is a volume of plasma autologous blood having platelet level higher than the peripheral blood concentration. And it contains multiple growth factors that are platelet drive and transforming growth factor, vascular, insulin-like, and epidermal growth factors. Aim and objectives of our study is to evaluate the clinical effects of the intra-articular injection of PRP and to study the safety and efficacy of the PRP. Our study is prospective cohort study conducted on the 100 patient in ortho OPD for 1.5 years. Inclusion criteria were age of patient between 35 to 80 years, grade 1 to 3 of knee joint osteoarthritis as per Kellgren-Lawrence classification, and ability of patient to understand and give informed consent. Exclusion criteria are further, but the important criteria are patient previously operated in the same knee joint and patient formerly treated with injections of PRP and hyaluronic acid and steroid injections, and patient with grade 4 osteoarthritis Kellgren-Lawrence classification. In the methodology, patient came to the OPD with the symptoms of knee osteoarthritis went for the radiographic examination. On that exam imaging, we classify the knee osteoarthritis into the Calgren-Lawrence classification. On the basis of that, grade 1, 2, 3 further including in the study and underwent the routine blood investigation. All the 100 patients were subjected to visual analog scale and Western Ontario and McMaster University Index for pain evaluation prior to treatment and during the follow-up at 1, 2, 6 and 12 months. How to make a PRP? We make PRP with the double spin method. First, we withdraw the 20 ml of blood in the sodium acetate anticoagulant tube. Then collected blood spun down using the autologous platelet separation system at 1000 rpm. After that, we get the 3 separated layer obtained. The upper layer is of the plasma. That layer is separated and transferred into the plain vial and again centrifuged for the second time at 2000 rpm. Then 2 layers obtained. The lower layer is the platelet rich plasma. Then we prepare the site and flex the knee 90-degree and painting and draping was done. We take 8 ml of PRP and 1 ml of calcium gluconate and injected through the spirolateral approach. After that, bandage applied and advised patient for the bed rest for 2 days. 2 further PRP injection given to the patient. Same protocol followed after an interval of 1 month each and follow-up taken. Now the results. In the results, in our study, the mean age is 56.37 year. The majority group belongs to 51 to 60 year and least common group belongs to 30 to 40 years. Male were 54% and female were 46%. According to grade wise distribution, grade 1 having 32 patient, grade 2 56 and grade 3 12 patient. Now comparison of WOMAC score pre and post treatment. As we can see, for pre-treatment and the follow-up score showing the decreasing trend, that means there is the improvement in the pain grade in the all 3 grade of the knee osteoarthritis. Now VAS score also shows the similar results as the WOMAC. There is also the improvement in the pain scale in all 3 grades. Now discussion. Previous studies and researches have shown that as the age advances, both the incidence and prevalence of osteoarthritis increases. In our study, mean age of the study participants was 56.73 years. In other studies, it was 56.1, 56.4, 47.9, and 56.7 years. In our study, the gender differentiation was such that 54% of the participants were male, while 46 were female. In other studies, it was 60% male and 40% were female. All these study participants were subjected to pre-treatment and post-treatment evaluation with the help of both WOMAC score and VAS. In all 3 grades of osteoarthritis, a significant decline was seen in the WOMAC and VAS score at each subsequent follow-up visit. Similar results were seen in the study conducted by Bansal et al., in which significant changes in the WOMAC baseline and post-treatment score were seen. Now conclusion. The result obtained in this study indicates that intra-articular injection of autologous PRP in a patient with osteoarthritis of knee has a significant and satisfactory effect in reducing pain and restoring functions. The simplicity and safety of PRP therapy makes it an ideal treatment modality for both the patients and clinician. Thank you very much.
Thank you, Dr. Yaskaran. I have 2 quick questions. The first question is, what is the score pattern immediately following the injection versus at the end of 1 year of your study or at the end of your study?
Sir, the score, mainly the WOMAC and VAS, they are showing the decline results.
No, my
They are
question is immediately following the injection or within a couple of weeks versus at the end of the study. It's a declining pattern. Immediately there is a decline and there is a dip. Then again it goes on dips. How it is?
No, sir, there is a declining pattern. There is a steady decline.
So steady declining.
Yes, sir.
That's what you mean. That's
Yes,
number
sir.
one. All right. Okay. How much ml of PRP you have given?
Sir, we give, sir, around 7 to 8 ml of the PRP, and we also take 1 ml of the calcium gluconate with it.
Right. Okay. Thank you. Any more questions from our friends?
All these patients you had, did they have any mechanical malalignment as well, or purely only majority of your injections were grade 2, which is what the common practice is. Some were grade 1 and none were grade 4. And the grade 4, you didn't select them or you didn't use them because probably they already had some varus deformity or valgus deformity.
Yes, sir. Sir, in grade 4, sir, that is over the exclusion criteria. So in grade 4, we don't use the PRP. We use in the first 3 grades, and majority of the patients were from the grade 2.
Any of them post-traumatic osteoarthritis?
No, sir. Sir, there is only the primary osteoarthritis. We don't take the secondary osteoarthritis or.
So inclusion criteria is purely primary osteoarthritis.
Yes, sir. There is no case of the secondary osteoarthritis.
Okay.
Thank you. Any more questions? If there are no more questions, thank you, Jaskiran, for a nice presentation. Now let us go to the second paper, that is PRP versus hydrodilatation in adhesive capsulator of the shoulder, a comparative analysis by Girinivasan. May I have the paper?
Yes, sir.
Warm wishes to everyone of YSCon from the Orthopedic Research Group. I am Dr. Girinivasan Chilamuthu. I am Research Associate. Today I am here to speak on adhesive capsulitis. I am presenting a study by our team on hydrodissection versus PRP. It is actually a comparative randomized control trial. So what is adhesive capsulitis? According to Codman, it is difficult to treat, difficult to define, and difficult to explain from the point of view of pathology. So after many years of research into adhesive capsulitis, this definition still remains true because of the vague presentation of adhesive capsulitis association with a variety of conditions and difficulty in managing these conditions. It was initially termed as frozen shoulder by Codman, who termed this condition as the one which is associated with tendinitis with the loss of motion. The more specific term of adhesive capsulitis was coined by Neiweiser, who based his findings on the involvement of capsule in the disease to use this term. So adhesive capsulitis is nothing but a capsular contraction and insertions across the glenohumeral joint, which in turn leads to loss of pain, stiffness, and loss of range of movements. Histologically, transformation of fibroblasts into myofibroblasts with altered levels of matrix metalloproteinases is seen. So it can be primary or secondary. Primary is generally idiopathic, whereas secondary can be associated with a variety of extracapsular causes like rotators of tear, biceps tendinitis, calcific tendinitis, glenohumeral arthritis, and acromioclavicular joint arthritis. So the primary or the idiopathic condition is the one which we are going to deal with in this presentation. The secondary condition is managed by managing the actual cause of the disease. The primary condition can be divided into 4 stages. The first stage is the painful stage, or the stage 1. In this stage, there is no loss of movement, but there is actually pain. The stage is similar to other shoulder conditions with a non-specific pain, but the pain is actually present at the site of insertion of the deltoid, and the patient has more pain in the night with the difficulty of turning to the side of the pain. The second stage is called the freezing stage. In this stage, the loss of movements actually begins. It is usually the external relation that is the first movement to get lost. In the first and second stages, there is active inflammation. The third stage is called the frozen stage. Almost all movements are lost in this stage, and the pain has come down significantly When on examination, we will actually feel a physical resistance to the range of motion. The third stage is the thawing stage, where the resolution has begun and the patient starts to gain the range of motion. The natural history may progress up to 12 months into 4 stages. When the disease is not always still self-limiting, in some patients it may lead to long-standing disabilities. So coming to the management part, the stage 1 and stage 2 can be managed by oral NSAIDs along with targeted physiotherapy plus steroid and intra-articular lignocaine injection. Steroid plus intra-articular lignocaine injection completely resolves the pain, particularly in stage 1 when compared to stage 2. Coming to the role of oral NSAIDs, they can always be combined with physical therapy to improve the compliance in the physical therapy. The physical therapy is different for all 4 stages. It can be employed in all 4 stages, but it is different in all 4 stages. In stage 1 and 2, it is mainly aimed at preventing the loss of range of motion, whereas in stage 3 and 4, it is mainly aimed at restoring the range of motion. So in stage 3 and 4, it is particularly stretching exercises, whereas in stage 1 and 2, it is gentle range of motion exercise along with transcutaneous electric nerve stimulations, iontophoresis, etc. In stage 3 and 4, we can't use intra-articular steroids and intra-articular local anesthetic injections because the inflammation has already settled in these stages, so there is no use of steroids. In these stages, particularly, only oral NSAIDs and physical therapies are helpful. If there is failure to respond to oral NSAIDs and physical therapy for a period of over 4 months, then intervention is justified according to literature. So what are the options we have for intervention? One is mobilization or anesthesia. The second one is hydrodissection or hydrodelineation or hydrodilatation. The third one is arthroscopic capsular release and synovectomy, and the fourth one is suprascapular nerve block. So PRP is a newer modality of treatment that is being tried as an intervention in stage 3 and 4 of frozen shoulder. So in this study, we are actually going to compare the effects of hydrodissection versus platelet-rich plasma injection into the shoulder. This is actually a randomized controlled trial. We had 123 patients, of which 23 were not willing to study or excluded due to other reasons, and out of 100, 50 were randomized into PRP injection and 50 into hydrodissection group. Of these, excluding the patients lost to follow, we analyzed 46 patients in the PRP group and 45 patients in hydrodissection group. Coming to the PRP preparation, we used a leukocyte poor preparation which has been prepared by a pre-packaged kit. 10 ml of venous blood was drawn. It was added to the pre-packaged kit, which contains sodium citrate anticoagulant and thixotropic gel. This was centrifuged at 1500 rpm for 5 minutes to yield 5.5 ml of 80% platelets, which was about 1.6 times the concentration of actual platelets in the blood. This was then used for injection. Coming to the injection technique, all patients were taken to operation theatre. This is a double-blinded study where the patients or the operation surgeon had no idea about which patient is getting which drug. So the landmarks were palpated below the posterior angle of the acromion, 1 centimeter below the posterior angle of the acromion. The injection was then directed towards the coracoid. 3 ml of PRP was injected in group A and 20 ml of normal saline along with 5 ml of lignocaine was injected in group B. Follow-up. We evaluated visual analog scale, dash score and range of motions. Visual analog scale is nothing but a pain scale ranging from 0 to 10, where the patients interpreted their pain from no pain to pain as badly as possible. It could be in a numerical value. The dash score are the disabilities of the arm, shoulder and hand score consisted of a 30-item self-report questionnaire. It described the difficulty experienced by the patient as well as helped to monitor the changes in the symptom and the function over time. So this is actually the dash score. We assess the dash score of all the patients using orthopedicscores.com website. So these are our results. In 6 and 12 months, particularly, there was a reduced VAS score in patients treated by PRP group. Also, there was a reduced dash score in patients treated by PRP group. Both of these were statistically significant. So concluding, the platelet-rich plasma is an easy, safe, biological and effective alternative when compared to hydrodissection method in stage 3 and 4 of adhesive capsulitis for patients who are not responding to conventional conservative treatment. Thank you.
Thank you, Dr. Giri. My question is, you are comparing two different modalities. One is a mechanical modality and one other is an anti-inflammatory modality, or whatever it may be, regenerative modality. And you have not mentioned about the even at the 6-month end or 12-month end, what is the total range of movement of the shoulder in both the groups? You mentioned only about the pain, we agree, but what about the mobility and range of movement in both the groups? Which group scored better? Dr. Giri, are you in the line? Dr. Girivasan. Yeah, if he is not on the line, then we move on to the third paper. That's a prospective study to evaluate the efficacy of the bone marrow concentrate in chronic aseptic inflammation by Radhik.
Hello everyone, I am Dr. Radhik, second year postgraduate in Department of Orthopedics, Narayana Medical College, Nellore. My oral presentation is on efficacy of percutaneous bone marrow concentrate in the treatment of chronic aseptic pneumonia. Introduction. In 1963, the first quantitative description of self-renewing activities of transplanted mouse bone marrow cells were documented by Canadian researchers Ernest A. McCullough and James Hittel. In 1966, mesenchymal stem cells were first described as bone-forming progenitors from the stromal fractions of rat, Riefenstein and Petrokova. In 2001, Fred Lander in level 1 study found beneficial effects for the use of RHBMP7 for the tibial non-union when compared with iliacrest bone grafting. In 2005, Herning et al. Reported the use of percutaneous bone marrow aspirate in the successful treatment of 53 of 60 tibial non-unions. In 2010, Garnovas et al. Published the first intramedullary nailing and percutaneous autologous concentrated bone marrow grafting can promote bone healing in humeral shaft fractures with a delayed union. Bone marrow aspirate concentration is obtained through a density gradient centrifugation of bone marrow, typically aspirated from the iliac crest, similar to PRP as it contains platelets and growth factors. Bone marrow aspirate concentrate may possess high potency for osseous defect healing because it contains stem cells and multiple growth factors. Bone marrow is a good source of prostate progenitor cells that have the potential to proliferate and differentiate into osteoblasts. Traditionally, autologous iliac bone graft has been used in the treatment of non-union. This technique has its associated morbidities, which includes donor site pain, infection, scarring, and nerve injuries. The use of percutaneous bone marrow stem cells avoids these morbidities, which possible compared with clinical results. Aim of the study to evaluate bone marrow concentrate efficacy in chronic aseptic non-union. Inclusion criteria: non-infective non-union of long bones. Exclusion criteria: aplastic anemia, blood dyscharias, and infective non-union of long bones. Materials and methods. Our study consists of 10 cases of aseptic non-union of long bones, include femur, tibia, and humerus. The patients were treated with bone marrow concentrate in Narayana Medical College and Hospital. This study was carried out to evaluate bone marrow concentrate efficacy in non-union of long bones. All of the cases of non-unions were followed up at regular intervals. Surgical techniques. Bone marrow concentrate preparation. The bone marrow aspirate concentrate protocol involves two separate but related procedures. The aspirate procedure performed by a physician and transferred into sterile container. The concentration procedure: 60 ml of bone marrow aspirate was centrifuged at 3200 RPM for 14 minutes, and then the concentrate has been obtained from the lower end of the container. In a normal OT table, the parts painted and draped under CM guidance using a steam and spin through a stab incision. Fracture ends were freshened and incision closed with ethylene using matter switches. Through a new entry, fracture sites was approach and bone marrow concentrate is injected. Post-operative protocols. Patient discharged at second post-op day. Advised appropriate mobilization as pre-injection status. Sutures removal done on 12th POD. Patient followed up with a post-operative radiograph at 6 weeks, 3 months, 6 months, and 1 year. In case 1, a 20-year-old male went with an RTA for 6 months and was diagnosed with left leg both bone fracture with grade 3A compound injury, and now has been come to Narayana Medical College with left fibrous non-union of both bone with Ilizara incident done elsewhere. We have freshened the edges and injected bone marrow aspirate. The post-operative X-ray so significant amount of callus formation. Coming to our second case, this is a case of non-union fracture of humerus treated with dynamic compression plating. The 6 months lapse following initial fixation, still there is no signs of union, for which we have freshened and freshened the fracture ends and induced bone marrow aspirate. The post-operative X-ray shows significant amount of callus formation. This is a case of non-union of femur with the unipolar limb reconstruction system for over a period of 6 months. Now he has now we have depleted and freshened the edges and injected bone marrow aspirate concentrate. On the post-op X-ray at 10 weeks shows significant amount of callus formation. Coming to case 4, this is a case of hypertrophic non-union of tibia and fibula fixed with intramedullary nailing for 3 months. And now we have freshened and treated with bone marrow aspirate. At post-operative 6 weeks, there is a visible amount of callus formation. Coming to the results, on our observation of non-union in 10 cases, we observed the chronicity of non-union and is classified by open and closed and parallel classification, in which we see the volume of callus formation in the time of union. The average time, there was an average of 30,418 cubic millimeter of callus formation with a minimum of 4,245 cubic millimeters and maximum of 16,160 cubic millimeters. The time of union, the average time of union was 12 weeks with a minimum of 6 weeks and maximum 24 weeks. Discussion. In the case of non-union, our study has significant union results where we had 20,418 cubic millimeter of callus with an average healing time of 12 weeks. In case 1, which was a complex case with a grade 3A open fracture with Ilizara fixation done, had not united for 6 months, but after bone marrow stem cells had good results, healing in 12 weeks and with a callus volume of 69,160 cubic millimeters. In our case 4, of 4 months of chronicity of non-union healed in 6 weeks and had a callus formation with a volume of 14,130 cubic millimeters, which suggests that duration of non-union above the time of union. Also, the average time of union was 12 weeks. This compares well with our results, which was also 12 weeks. In 2001, Devnani et al. Did a study with a plate fixation, the cancellous bone grafting for the treatment of non-union of shaft of long bones, where all non-unions healed on an average of 18 weeks. In contrast, the treatment of non-union with bone marrow stem cells takes lesser time to heal and also fewer complications such as donor site morbidities. When there is a gap union of more than 1 centimeter, autologous bone graft may be superior to bone marrow stem cells. Coming to conclusion, on measurement, there was an increase in callus value and decrease in time of union and less morbidity. Comparing with the other historical means of treating non-unions, our series of case shows excellent results and good healing, chronic, long-standing aseptic non-union. So bone marrow is a very promising tool for regenerative medicine. Thank you.
Dr. Radik, are you available? Dr. Radik, are you available? Hello? Dr. Radik, are you available for the discussion? Any other questions for the question answer session? I think he is not available. So we'll move on to the next paper. That is the corticosteroid therapy versus percutaneous needling with autologous PRP therapy for recurrent stenosis tenosynovitis by Dr. Dushyant Chowdhury. May I have the paper?
Good morning, everyone. Today I am presenting my paper on functional outcome of autologous platelet-rich plasma therapy versus corticosteroid injection in early knee osteoarthritis. Myself, Dr. Dushyant, resident in orthopedics in Sharda Hospital. Hyaline cartilage enables the friction-free joints movement and has limited intrinsic healing potential because it is avascular and has few specialized cells with a low mitotic activity. Once the cartilage is injured, it gradually degenerates, leading to osteoarthritis. And in osteoarthritis, there is an imbalance between the rate of cartilage degeneration and rate of repair. The desired therapeutic effect of platelet-rich plasma is facilitated by the ability of IL-1 RA to limit the destructive inflammatory intra-articular actions of IL-1B. Objective of this study is to evaluate the efficacy and the functional outcome of autologous platelet-rich plasma therapy and corticosteroid injection in patients with early knee osteoarthritis. Material and methods used are patients with symptomatic knee osteoarthritis who satisfy the inclusion criteria of attending orthopedics OPD. The sample size we have taken is 121. The study design is prospective cohort study. Sampling design is convenient sampling. Duration of this study is January 2019 to December 2019, that is 12 months. The inclusion criteria for the patients are the patient with age 30 to 80 of both sexes, both male and female, patient with radiological osteoarthritis knees, Kellgren-Lawrence grade 1 and 2 based on X-ray findings, and patients with severe pain and under anti-inflammatory treatment without improvement for 3 months. Patient who has given consent for treatment as per our protocol and regular visit in the OPD department. The exclusion criteria are patient with age less than 30 and more than 80 years of both sexes are excluded in this study. Patient with advanced osteoarthritis according to Kellgren-Lawrence grade 3 and 4 based on X-ray finding. Patient with a history of prior corticosteroid injection at treatment site within 3 months of duration. Patient with RA inflammatory arthritis or polyarticular arthritis or any autoimmune disease. Patient with HB less than 10 gram per dl and platelet count less than 10 liter with local infection at the site of the procedure, HIV, hepatitis B or C, septicemia and other metabolic disorders, bleeding and other coagulation disorders. This is how we prepare platelet-rich plasma (PRP). That first we withdraw the blood of the patient in a test tube. Then we centrifuge the blood sample. Third, in the test tube, the 55 of the host blood with least dense component, that is plasma, and there is a buffy coat of leukocytes and platelets, and then erythrocytes, 45% of the whole blood, and it's the most dense component which we use. Preparation of PRP. The 20 ml of venous blood withdrawn in sodium citrate tube. Then first centrifugation is done at the rate of 3000 RPM for 10 minutes. Then the plasma and the buffy coat separated from the RBC into plain tubes. Then the second centrifugation is done at the rate of 5000 RPM for 10 minutes. Then top 2/3 portion of that platelet poor plasma, that is 60%, is removed, and that bottom 1/3 portion platelet rich plasma, that is 40%, is used. Now the procedure of PRP injection. Thoroughly paint the knee with betadine and spray. Identify the medial joint line of knee. 4 ml of PRP, 40% and 10% calcium gluconate or 10% calcium chloride in the ratio 10:1 or 0.4 ml of thrombin concentrate is injected into the knee. Then we do the sterile dressing with crepe bandage. These are the pictures showing intra-articular injection of PRP left knee, and this is USG guided intra-articular PRP injection. Procedure of steroid injection. Thoroughly paint the knee joint and betadine and spray. Identify the medial joint line of knee. 1 ml of trimiclonine injected. Sterile dressing done and crepe bandage is applied. Data collection. In group A, we take and 63 receive autologous PRP injection. In group B, receive intra-articular corticosteroid injection. Both the group participants are followed up procedurally on day 0 and post procedurally at the end of first, second, and 6th month of pain relief and range of movements of knee. The improvement in pain and range of movement are charted in terms of VAS score, Q score, and WOMAC scoring system. Statistical analysis. SPSS for Windows V24 version 24 is used. Chi-square test was used to compare the observed and expected frequencies in each category. Statistically significant if the p-value is 0.5. These are the result demography statistics. This is the number of patients cured. Group A, in Group A we took 63 and Group B we took 58 patients. This is the functional assessment of Group A patients using VAS, QOS and WOMAC score. We get a good significant results. This is Group B of VAS, QOS and WOMAC scoring system. We don't get much good results. This is a functional outcome. Now the results. We observe a statistically significant result by the end of first month follow-up and statistically significant result by the end of second and 6 months follow-up. Complications which we got in Group A is pain in 12 patients, swellings in 29 patients, and recalcitrance in 8 patients. In Group B, pain in 2 patients, recalcitrance in 44 patients. Now the discussion part. Osteoarthritis knee is a progressive chronic joint disorders lead to pain and loss of function that reduces the quality of life. Histologically, hallmark destruction of articular cartilage by IL-1. Platelet-rich plasma offers great advantage of biologically healing cascade in antagonizing 1R and provides anabolic growth factors to maintain joint credibility and hemostasis. This is a plasma blood PRP's micro zoom picture. This is whole blood. This is PRP. The volume of plasma in an exponential increase platelet concentration to of 5 to 6 times above the baseline. This contains 94% of platelets. The growth factors are PDGF, TG-beta, VEGF, IGF-1, EGF. Growth factors are polypeptide dimers with 2 anti-parallel monomers arranged in cysteine node configuration and acts through the tyrosine kinase receptor pathway, which leads to transcription, translation, cell division, and migration. Platelets with microRNA 23B helps in differentiation of mesenchymal cells into chondrocytes. At the end of 6 months, the average VAS, QOS, and WOMAC scores improved in Group A while comparing with Group B. PRP injections have proved in reducing pain, improved joint motions and function, enhanced quality of life in patients with early knee osteoarthritis. Limitations of this study are potential of PRP injection is not validated. Longer duration of follow-up is needed for the evaluation long-term benefits of autologous PRP injection in early knee osteoarthritis. The conclusion is PRP injection has the potential to offer disease-modifying chondroprotective and biological and molecular approach in treating pain and functionality in patients with mild and moderate knee osteoarthritis. Thank you.
Thank you, Dr. Dushyant. Any questions from our audience about this paper? Dr. Dushyant. Dr. Dushyant? Right. I think Dr. Dushyant is also not available. Then we go to the last paper, that is by Dr. Arnab Arora, regenerative therapy in delayed and non-union of the fractures. The last paper of the session. May we have the last paper?
A very good evening to one and all. I'm Dr. Arnab Arora, doing my post-graduation from School of Medical Sciences and Research, Sharda University, Greater Noida. I'll be presenting on regenerative therapy in delayed and non-union of fractures. Delayed union is described as an ununited fracture that continues to show progress towards healing or has not been present long enough to satisfy an arbitrary time criterion for non-union. The lack of precision in its definition decreases its value in reports of results. Whereas non-union is defined as fracture that is at least 9 months old and has not shown any signs of healing for consecutive 3 months. Bone regeneration. In recent years, the process of bone regeneration has been greatly enhanced by the identification of growth factors and the technologic means to use them. The availability to enhance the regenerative process of the human body by utilizing a patient's own blood is something that is now available and is substantiated in the literature. This can be done today by the use of autologous platelet-rich plasma, the application of growth factors such as platelet-derived growth factor and transforming growth factor beta is seen as an available proposition for enhancing the rate of bone formation and the final quantity of bone formed. Platelet-rich plasma was first defined in 2007 as a preparation of platelets present in a small volume of plasma containing a large amount of growth factors, which is essential for bone growth and regeneration. The benefits involved in the application of platelet-rich plasma in the regeneration of bone involve its availability, ease of isolation, good handling and storage properties, and its application in the field of bone tissue engineering. Zones of platelets. Here, we are mainly concerned with the organelle zone, where the alpha granules are present. Alpha granules contains P-selectin, platelet factor 4, transforming growth factor beta 1, platelet-derived growth factor, fibronectin, beta thromboglobulin, fibrinogen, and coagulation factors such as 5 and 13. The delta granules contains ADP or ATP, calcium, and serotonin. The gamma granules contains hydrolytic enzymes. Lambda granules are involved in clot resorption during later stages of vessel repair. Now, how do we prepare PRP? 30 ml of venous blood is withdrawn from the patient in sodium citrate vials. The first centrifugation is done at the rate of 3000 RPM for 10 minutes. Plasma and buffy coat, which is obtained, is separated from the RBC layer into the plain vials. Then second centrifugation is done at the rate of 5000 RPM for 10 minutes. The top 2/3 portion of platelet poor plasma is discarded and the bottom 1/3 portion of platelet rich plasma is used. Rationale for PRP activation. When platelet gels are formed using calcium chloride, growth factor release can be slowed. Hence, calcium chloride activates and clots platelet-rich plasma by forming autogenous thrombin from prothrombin, leading to the eventual formation of loose fibrin matrix that will release growth factors over 7 days. As bone regeneration is a lengthy process, there is an obvious need for effective delivery vehicles capable of sustained release of platelet-rich plasma-derived factors over an extended period of time to maximize their regenerative potential. I'll be showing some cases, 5 in number, which contains delayed union and non-union cases. This is subject 1, 43-year-old male. He had an alleged history of road traffic accident on 20th of August 2019. He sustained fracture of the mid-shaft of the humerus, left arm, with multiple injuries. He was primarily managed non-operatively by giving him a U-slab. He received first dose of autologous PRP injection on 22nd of October 2019, and then subsequent doses every 3 weeks for 3 doses were given to him. On your left, you can see under aseptic precautions, we gave him platelet-rich plasma. On the right side, under the CIAM image, the defect site was identified and the platelet-rich plasma was given. In the subsequent X-ray, you can see the patient when came to follow up, the medial cortex was seen. The callus formation in the medial cortex is seen. This is another X-ray of the patient during the follow-up. Here, the medial as well as the lateral cortex is seen of having callus formation. Case number 2, he is a 28-year-old male. He sustained trauma to his right femur with fracture of the distal end of the femur on 20th of March 2019. He was operated for the same on 24th of March 2019. However, he did not show any signs of union till 11th of November 2019. Therefore, he was started on autologous PRP injection on 4th of December 2019. These are the images showing the X-ray of the patient and the PRP injection towards your right under the CIAM guidance. This is the X-ray of the patient showing callus formation on the medial cortex. There is another X-ray of the patient showing callus formation on the lateral cortex as well. Case number 3, she's a 26-year-old female. She had intercondylar fracture of the left humerus and was operated in July 2019. She came for autologous PRP therapy in December 2019. However, the first dose of PRP was given to her on 11th of Jan 2020, and she received subsequent injections every 3 weeks for 3 doses of PRP. On your left, you can see the C-arm image where the defect was identified under the C-arm and platelet-rich plasma injection was given. On your right, there is image of the subsequent follow-up where we can see that new bone formation has started. This is the subsequent X-ray of the patient during the follow-up. This is the X-ray of the patient taken in August 2020, where we can see the gap has been filled. This is case number 4. She is a 58-year-old female. She sustained fracture in the mid shaft of the femur after sustaining a trivial fall at home. She was operated in 2019, October. She received her first dose of autologous PRP injection on 5th of December 2019. These are the images under C-arm where the defect site was identified and PRP injection was given at the same site. This is the follow-up X-ray of the patient where we can see that the callus formation has started on the medial cortex of the femur. This is the further follow-up X-ray of the patient. A last and the final case, he's a 60-year-old male. He sustained fracture both bone right leg in December 2019 and was started on autologous PRP injection on 13th Feb 2020. On your left, under C-arm guidance, the patient was given PRP injection. On the right, we can see the follow-up X-ray of the patient, where we can see that the medial, callus formation on the medial side, on the medial cortex of the tibia, and on the lateral cortex of the fibula. This is the further X-ray when the patient came for follow-up. This is the X-ray taken in August 2020 of the patient, where we can see the full union of the bone. Now to conclude, the use of PRP in bone defects is the challenge of retaining PRP growth factors at the defect site in a physiologically active state. The ability to reduce the challenges faced and to provide a sustained release of platelet-rich plasma biomolecules may be critical to expedited healing of bony defects. Therefore, PRP is a promising biological therapeutic agent as a scaffold in micro-invasive bone and soft tissue regeneration, not only for its content of proliferative and differentiative growth factors, but also for the presence of anti-inflammatory agents. Thank you.
Thank you, Dr. Arnab. Are you available live? Dr. Arnab?
Sir, Dr. Arnab is online. He's there.
I have a question for him, that's why.
Yes, sir. You can ask. He's unmute now. He's online, sir.
Yeah, ask him to unmute. And Dr. Arnab, you have shown 5 cases. Out of them, the first case, what is the rationale in managing the humerus fracture conservatively, number 1? And after giving the PRP injection, how do you ensure the fracture is immobilized?
Dr. Arnab?
Ask him to unmute. Dr. Arnab, please unmute. Yeah.
He's unmute only.
Yeah. Is he able to hear?
1 minute, sir. 1 minute.
Yeah.
Actually, he's my student only.
Okay. You
Can
want
I
to
answer?
answer Anuj? Yeah, please.
Actually, this case was done by me and Arnab only. Actually, this case came after 9 months of non-clinical and radiological non-union. We have given PRP as well as we have immobilized with UCAST. We have given with UCAST.
You know, my question is, Dr. Madan, my question is, you know that it's
Yes,
an
sir.
established non-union
Yes, sir.
because it has not been surgically answered.
United. Yes, sir.
No, it is not. It is managed conservatively. I put that way. And after 9 months, we still have a classical non-union. Perhaps that may be because of improper surgical stabilization or lack of surgical stabilization. What prevented you to do the surgical stabilization and then give PRP? What is the rationale in still giving a conservative management and do the PRP injection? That's my question.
Patient had multiple injuries actually. He had femur fracture, even leg fracture also, ipsilateral femur and leg. So we have surgically managed femur and this leg, and he was little bit denial for surgical treatment for humerus. So in 9 months back, he has opted only for conservative. Still after 9 months also, he was ready only for conservative management. So we gave the options. These are the available options for conservative management. Then we tried PRP. After getting proper consent, everything we explained. Even this can also fail. You may have to go for bone grafting later with surgical stabilization. So the patient agreed all those things. Then we started with PRP management, and we have stabilized the fracture externally with UCAST.
Okay, right.
Yes,
okay.
sir.
Thank you. Any more questions? Any more questions?
The last case, which is the tibial fracture in December 19.
Yes, sir.
And the PRP in February 20. So that's only about 2.5 months gap.
So that we took it as a delayed union, sir.
No, what
delayed
is
union.
your general protocol for weight bearing on low fractures? What is your protocol for mobilizing them after fixing them in lower limb fractures in particular? Because I see a lot of places in this country very differently and a lot of reluctance to weight bear the patients.
Dr. Arnab, can you answer Dr. Kosigan?
Sir, actually for this particular project we are following. Yeah, Dr. Arnab is online. Arnab?
Yeah,
Arnab?
he put it very clearly in the beginning of the definition for non-union of two type of definitions. One is the based on duration, and two is based on no consecutive progress over a period of 3 months. So I think, yeah, anything beyond 6 months is certainly a cause of concern. And as you know, in tibial fractures, sometimes dynamization is what you need when you begin them to weight bear. But generally, I find a lot of people, they don't let them weight bear in spite of a very solid fixation, even in young adults.
I think Dr. Madan, you can answer on his behalf, Dr. Arun.
Arnab? I think he is on.
We're able to see him, but he's not answering. You can answer, Dr. Madan. No problem. No problem. Because he said he is your student. You can answer on his behalf. What sir is asking, what is the protocol followed in the last case? Am I right, Dr. Kosigan?
Yes, yes. Generally, for low limb fractures, we all have a different weight bearing protocol, and some are really reluctant in spite of a solid fixation, even in young adults. And there are other cofactors like smoking and other things for non-union. He put it very right at the beginning that 9 months is usually what is defined as non-union. And the other thing he put is no progress over 3 consecutive months. And that is a cause for concern if you don't see anything around there. Because it's so difficult to see callus in a very rigid intramedullary fixation as a sign of union on X-ray.
Hello. Can you?
Dr. Arnab.
Sir, can you hear me, sir?
Yeah, we are able to hear you. Dr. Jairam.
Yes.
Hello, Dr. Madan.
Sir, I think internet issue, sir.
Yeah, some internet issues are there.
Post rain and
Dr. Madan.
Yes, sir. Yes, sir. Sorry
Yeah,
for
please.
the disturbance.
No problem.
Sir, in our project, what we have allowing is in low limb fractures, after 6th week, we are allowing the patient to walk, weight bear. 4 weeks, we are allowing, after 4 weeks, we are allowing for partial weight bearing, and 6th week to 7th week, we are allowing them for complete weight bearing. So here 10 weeks has got over, 2.5 months has got over. We put it as a delayed union. We have taken a protocol above 8 to 10 weeks if the fracture is not united. We are taking it as a delayed union. So we are taking both delayed union and non-union for PRP bone regeneration here. So we have given that PRP injections for that to unite.
okay. Yeah, that's my concern in general. In spite of a very rigid fixation, good alignment, and in young, strong bones also, I really don't know what is the reluctance in making patients
Weight
from
bear,
day one.
yeah.
I weight them. I'm an aggressive mobilizer even with the ankle, unless it's an extremely osteoporotic elderly patients who can't understand or manage the so-called partial touch and full weight bearing. I think young people should be mobilized weight bearing, particularly when you have such a nice fixation in terms of alignment, bone quality, and the fibula has also been stabilized. And I think
yes, sir.
If you load them from day one, you will see less of this. Number two is some X-rays in the earlier presentation. I've seen PRP or BMAC is combined with the dynamization. In your last one, I think it was not dynamized, but it's still gone on to unite. And because if you're not weight bear, not letting them weight bear for 6 weeks, so technically only from mid-Jan to February of that year, you've actually let them weight bear. And loading is really important for
lower limb fractures.
Yes.
Okay, sir. Okay, sir.
And earlier, what Krish was alluding to was polytrauma, particularly, is one indication. Generally, yes, humerus is a good bone to leave alone. And actually, non-unions can be more of a problem when you actually fix them, and particularly if you fix them improperly. And humerus can go on to union when you actually leave them alone. And so is clavicle. So what he was alluding to was it's a polytrauma. And
Yes,
I think it's more of a case where we all end up even fixing clavicles because you want to let them hold the walker and move around and use some kind of mobility issues. So I think that was Krish alluding to earlier on as to was there any reason why maybe after your first 2 fixations, that is the femur and tibia, the patient was more sick. And of course, here we also have to take into the financial constraint. Maybe, you run out of the budget, the lower limb has to be fixed. They were fixed, and then come to humerus. Maybe you would have gone on to explain that it would probably cost a little bit more. We have to fix this also later on. And sometimes, yes, the patient say, no, please leave it. Can you manage without it? But generally, otherwise, in polytrauma, even the fractures which may not routinely need fixing, it gets fixed because to help them in the mobility.
That's right. Thank you. Any more questions on this paper? That's a good discussion. If there are no more questions, I'm very happy that the free papers also, all 5 papers are really, really interesting. And thank you very much for all the participants. Once again, I thank individually by name, the speakers, the faculty, the panelists, the participants. A very big thank you for making this session a grand success. And I think I look forward to meet more often on this particular topic of orthobiologics. Once again, thank you very much.
Thank you.
Thank you,
It's
sir.
well moderated. Thank you.